Yeah, now on my screen, I've opened another tab and it says start streaming soon. Stream starting soon, right? Now, shall I press the main one? All right, buddies, this is Dr. Nitin Bhagat. Always so good to be with you all. I hope I'm audible and the screen visible and there is no lag. Let me move my hands to check if there is any kind of lag. I've got my screen open in front of me to check if there is any kind of lag. Good evening, Dr. Ria the Rockstar. What a nice name, buddy. Right. Good evening. Okay, right. I'll just wait for 20-30 seconds more and then we'll start. First of all, as always, I must lament yet again that I'm always glad to be with you all, and I must thank Dr. 𝗵𝗵𝗀𝗀𝗀 sir for having given me this opportunity to interact with lovely people like you. Right? So let's start, because orthopedics is a small subject but an important one also. Scoring subject. So just with a little knowledge you will be able to score good. Thank you, Dr. Manish G. So are you, buddy. Right? Thank you, Dr. Dr.G. Right, buddies. So as of now, what is going to be our approach? First, you see, we will study some of the lower limb fractures. First we will see some important x-rays. Thank you. Hello, Dr. Diyash. First, we will see some important x-rays. I'll tell you how to identify the x-rays, right? Then we'll see some of the conditions affecting spine, and then upper limb fractures. Some of the splint and instruments we will see. All the pictures one. PDF I will share. Immediately after the class I will share the PDF. You won't have to remind me about PDF. That's my promise. Right? And then there are some important topics here. We'll have to study all of them. Now what I've done is I have written some of the things already. That pretty much saves our time. Right? That saves our time, so that already time is at a premium. Your exam is around 30 days away, right? So I don't want to take too much of your time, but I don't want to waste things either, right? This opportunity is as big as opportunity for you, as big as it is for me, right? So let's quickly start without wasting another time, right, buddies? So in exam they might ask you to identify some of the fractures, and then they will ask you how did this fracture occur, right? For example, if you can see over here, so this bone happens to be femur, this one happens to be tibia, and this one happens to be fibula. 110%, Dr. Shivani. This might be enough even for NEET PG, right? I will be covering all your PYQs. All your PYQs I will be covering, right? Okay. I'll speak. 110%, Mohit ji. Okay, what you see over here, this happens to be a tibial plateau fracture. It's going to be bilingual, don't worry. Tibial plateau fracture. So if you see a big fracture, अगर आप बड़ा सा fracture देखें tibia में, right? If you see a big fracture of tibia, what is this? This happens to be bumper fracture. जहां से भी आपने orthopedics पढ़ी, from wherever you have studied orthopedics, rather than writing the entire word fracture, what do they do is they use this logo, this hash symbol as fracture, right? So rather than, okay, it's there, I'll bring it up over here, right? This, right? So rather than using the entire word fracture, I'll use the hash symbol, right? Okay, so this is a bumper fracture. Now how can this fracture occur? See buddies, here this is car and this happens to be bumper of the car. So bumper of the car is going to hit the knee joint. अब क्या होगा, गाड़ी आगे आती जाएगी, car will come forward and this knee, this leg will go below the car. Fine. So what kind of force is this? This kind of force is valgus force, like this, valgus force, right? Valgus force, bumper fracture, important image based question. Okay, now see here, what did you see? You saw a big fracture. You know, one part of tibia is broken. तकरीबन टिबिया पूरी टूट चुकी, एक हिस्सा टिबिया का टूट गया, राइट? अरे इसमें भी ऐड आती है क्या? डू वी गेट टू सी एड्स? ओके, नाउ हियर if you see a small chip of tibia getting fractured, if you see a small chip of tibia getting fractured, small chip of tibia getting fractured, fine, okay, I think after a while they'll settle. Now see here buddies, if you see a small chip of tibia getting fractured, what kind of fracture is this? So this is a 𝗔𝗵𝗀 fracture. This is a 𝗔𝗵𝗀 fracture. Okay. This is a 𝗔𝗵𝗀 fracture. I don't want to comment on that. Okay. This is a 𝗔𝗵𝗀 fracture. Fine. So what is important about 𝗔𝗵𝗀 fracture? So 𝗔𝗵𝗀 fracture is associated with, AW means associated with, it is associated with ACL injury, anterior cruciate ligament injury, anterior cruciate ligament injury. That's the main stabilizer of knee joint, main stabilizer of knee joint. Right. Now, so there are two fractures here, Jones fracture and Dance fracture, Jones fracture and Dance fracture. Fine. So you see here, so both of them, they differ in the mechanism. So they affect the fifth metatarsal bone. What is ACL? Shivani beta, ACL is anterior cruciate ligament. I'm really sorry, I should not have used the short forms. ACL is anterior cruciate ligament, because this is a rapid revision, so I thought that maybe I can use some short forms, but if you want, I'll not use any short forms. Okay, anterior cruciate ligament, right? Okay, so Jones fracture. Now fifth metatarsal, you see here, first metatarsal, second metatarsal, third, fourth and fifth metatarsal, right? Now fifth metatarsal has got two kind of fracture. Dr. Puneet and Yash, just tell me one thing, had this question been put by some male doctor, would you have answered that quickly? So you see here, two fractures affect the fifth metatarsal, Dancer's fracture and Jones fracture. So Dancer fracture is an avulsion, pulling type fracture, okay, whereas Jones fracture, it involves the shaft of fifth metatarsal. Jones fracture, okay, very good. So Jones fracture and Dance fracture, right? They both affect the fifth metatarsal, right? Jones fracture and Dance fracture. Okay, now here, if you see buddies, these are the bones of the foot, right buddies? So here, metatarsals, right? And then the tarsal bone. After that, the tarsal bones are there. So that means when we speak about this joint is tarso-metatarsal joint. This joint is tarso-metatarsal joint. That means between the tarsal bones and metatarsal bones, tarsal bones and metatarsal bone, tarso-metatarsal joint. Name of this joint is Lis-Frank joint. Lis-Frank joint. Now, if a fracture occurs over here, this fracture would be called as Lis-Frank fracture. Lis-Frank fracture. Okay. Now, what is here? These are all the tarsal bones. These are all the tarsal bones. Sometimes what happens is fracture occurs here. So half of the tarsal bones, they are separated from the other half. Fine. Now, for example, see over here. So if you see, some of the tarsal bones, they are separated. Some of the tarsal bones, they are separated. These tarsal bones are separated from other tarsal bones. So दोनों बोन एक दूसरे से अलग अलग हो गई. So what kind of fracture is this? This is a chop-part fracture. Chop-part fracture. Fine? Chop-part fracture. Sometimes we cut the feet from here. Let's say this entire part has developed gangrene. पूरे पैर में gangrene हो गया. In that case, we will cut the part from here and this will be called as chop-part amputation. This will be called as chop-part amputation. So if we cut this much part, it will be called as chop-part amputation. Right? Okay. Now, so based on what we have studied till now from your own teacher, from me, please tell me what is the name of this fracture. You can see a fracture on the screen. Fine, what is the name of this fracture? Dr. Akash, मान लीजिए आपके मरीज को क्या हो गया जी, gangrene. Suppose your patient develops gangrene. There is no choice. Part is already dead. You'll have to cut it. Please identify the fracture which you see over here. Yes, exactly. So you see buddies here, these are like the metatarsals and these are like the tarsal. So this joint is broken. This joint is broken. So what you see right now is Lis-Frank fracture. Lis-Frank fracture. So Lis-Frank fracture is between tarso-metatarsal joint. This joint is affected. Tarso-metatarsal joint is affected. Right? Now, so let's say buddies, there is a fracture. भयानक fracture. टेलस के दो टुकड़े हो गए. टेलस is divided into two parts. So buddies, some of the doctors have asked me to speak in Hindi also. This will be a bilingual class. Whatever I speak in Hindi, that will be immediately and definitely translated to English. Most of it will be in English only. But if I speak one or two Hindi words, I'll definitely translate that to English. You don't have to worry about it. So you see here, which bone is injured? Talus. Fine. So talus bone is broken into two parts. So it is a fracture of talus neck. It is a fracture of talus neck. Fine. Now, so if the talus bone is fractured into two big pieces, fine. So this will be called as aviator fracture. This is common in parachuters. Fine. Parachute चलाने वाले लोग. Right? This is common in parachuters. Again, this will be asked as an image-based question. Okay. Now, so this bone is femur, this bone is tibia, and this one is fibula. Right? Now, if you see a fracture here, this is the fracture. This is the fracture. So this is Hoffa fracture. Hoffa fracture is basically fracture of femoral condyles. Femoral condyles. Yes, buddies. Akash Ji, as of now, we are just reading the image-based question. They will just come as an image-based question. Whenever the conceptual part comes, I'll tell you the tricks to remember. Don't worry. Right? Now, so remember buddies, here what we studied. we studied a big fracture of talus. Fine. So talus was divided into two parts. So if you see another small fracture here, if you see a chip fracture of talus, chip fracture, S for small. Fine. So that is called as Shepherd fracture. That is called as Shepherd fracture. Shepherd fracture. This may not be so important for FMG, but this is very important for NEET PG. Shepherd fracture. Shepherd fracture. Yes, Dr. Puneet Ji, you're right. Okay. Now here, this is fracture around the ankle. Fracture around the ankle. So there are two kind of fracture. Dr. Shrikast ji, don't worry buddy, don't worry, 90% of it will be in, okay, 100% of it will be in English only. At times, for Hindi speaking student, if I speak one or two words in Hindi, I'll definitely translate that to English. Okay, let it be English only. So if there is a fracture around ankle, now let's say medial malleolus is fractured, right? Let's say lateral malleolus. Enough of the language one, let's focus on the subject, right? Okay, lateral malleolus is fractured. So buddies, what has happened? Two malleoli are fractured. So if the fracture is bimalleolar, so we will say it is pot fracture. Now let's say if the posterior part of tibia is also fractured, so this is called as posterior malleolus. This is called as posterior malleolus. So if three malleoli are fractured, trimalleolar fracture, this one is called as Cotton's fracture. Cotton fracture. Fine. So pot bimalleolar and cotton trimalleolar. Cotton trimalleolar. CTBP. I mean, there's no specific mnemonic for this, right? Cotton's fracture is trimalleolar. Pot fracture is bimalleolar. Okay. Now we shall see some other important X-rays. Can anyone identify what kind of fracture do you see over here? Please allow me to zoom for you. What is the name of the fracture which you see over here? Yes, definitely. As soon as the class ends, you will immediately get the notes. Let me write it. Otherwise, you guys won't believe it. Yes, can you see any kind of fracture over here? Can you see any kind of fracture over here? So if you see, there is this fracture. Now this kind of fracture is called as Bhagath fracture. Bhagath fracture is that of glenoid. Bhagath fracture is that of glenoid. Bhagath fracture is that of glenoid, and this is associated with, so AW means associated with, this is associated with anterior dislocation. This is associated with anterior dislocation of shoulder. This is associated with anterior dislocation of shoulder. So fracture of glenoid, which is associated with anterior dislocation of shoulder, right? Okay. Now can you identify this condition? This is not a fracture certainly, but this conditions. Can you identify what exactly is this? What exactly is this? And in which disease is it seen? कोई बताएगा ये वाला एक्सरे हमें किस बीमारी में देखने को मिलेगा? We will get to see it in one form of arthritis. So that's an image based question. We'll get to see this in one form of arthritis. No. So this is seen in psoriatic arthritis. This is seen in psoriatic arthritis, and this particular condition, what you see on X-ray, this is called as ivory phalanx. This is called as ivory phalanx. Rohit Yadav ji, I'll show that what is pencil and cup deformity. I will show you that. But this particular X-ray is, ivory phalanx. Ivory phalanx. So when one phalanx appears brighter than the others, that is because of sclerosis, that is healing. That is called as ivory phalanx. Ivory phalanx. Right? It is seen in psoriatic arthritis. Right? Now, can you identify this fracture? What is the name of this fracture? Can you identify this fracture? Can you identify this fracture, buddies? हाँ जी मोहित सर जी, मोहित जी वन लाइनर हम लोग करेंगे, अभी बहुत करना है, ये तो कुछ इंपॉर्टेंट एक्सरेज हैं, राइट? सारे वन लाइनर कवर कराएंगे आपके, डोंट वरी. द ओनली थिंग इज कि आई विल हैव टू स्पीक इन इंग्लिश, तो इंग्लिश में मेरा भी हाथ तंग है, थोड़ा सा एडजस्ट कीजिए बस. No. This particular fracture is called as torus fracture. Torus fracture. So this occurs because of buckling of the bones. Buckling of the bone. So let's say normal bone is like this. Because of pressure like this, if there is pressure like this, part of the bone will buckle, will crush. Right? Cortical bulging. Exact, Dr. 𝗏𝗵𝗀𝗀𝗀 ji. Exact thing, exact terminology you have used. Cortical bulging. So torus fracture. Torus fracture. Right? Okay, we'll move forward. Now these are the common sites of malunion. These are the common sites of malunion. Right? Intertrochanteric fracture of femur. Intertrochanteric fracture of femur. Right? Here, this is also known as extra capsular fracture. Extra capsular fracture. Akash ji, osteoma, when the topic comes, I'll show many images of osteoma, promise. In osteoma, there will be a black center and white periphery. Now, intertrochanteric fracture, supracondylar fracture of humerus. Remember, supracondylar fracture of humerus, if it is malunited, it will give rise to gunstock deformity. It will give rise to gunstock deformity. Gunstock deformity. How to treat it? We shall treat it with the help of French osteotomy. Modified French osteotomy. Modified French osteotomy. Colles fracture, if it malunite, it is going to give rise to dinner fork deformity. It will give rise to dinner fork deformity. Dinner fork deformity. Right? Clavicle fracture is, very commonly it undergoes malunion. Very commonly it undergoes malunion. Why are you guys so worried? For 3.5 hours we are reading. My challenge that any question in NEET PG, any question in FMG is not going to be out of these 3 hours. Fine. We will discuss all the important topics and all the questions will be from today's lecture only. Right? That's the confidence. Okay. Now, you see, these are the common sites of non-union. These are the common sites of non-union. So these fractures, they don't undergo union. These fractures, they don't undergo union. They never get united. What is the definition of non-union? Fracture which fails to unite at the end of 9 months. Fracture which fails to unite at the end of 9 months. So this is the mnemonic. Fluts. Fine. So femur neck fracture, it undergoes non-union. So yes, everything common is poor blood supply, but in lateral condyle of humerus, the reason is muscle pull. The reason is muscle pull. So common extensor muscles, they pull the bone away. So that is why it does not unite. Lower third of ulna. Okay. Now many of you might be thinking that we don't want to remember too much in orthopedics. So just remember this and this. Okay. Scaphoid. This. So these are the common fractures which undergo non-union. Okay. Right. Now, here, what you see? So buddies, if you see anything at the upper end of humerus and you see there is a bone fragment, so this is SBC, that means this is a simple bone cyst, commonly seen at upper end of humerus, right? Now, what you see over here, this is called as trapdoor sign. Okay, so bone fragment, one bone fragment is inside the cyst, trapdoor sign. Okay, now these are the causes of bone cyst. Now this particular thing is important only for NEET PG. Right? So what are the causes of bone cyst? Brody abscess, eosinophilic granuloma, and chondroma when it is liquefied. Right? Chondroblastoma and hemophilia. So these are, that is the mnemonic here, beach. Fine. So these are the causes of simple bone cyst. Right? Okay. Now, what is this? This one is aneurysmal bone cyst. Now, how do I say that this is aneurysmal bone cyst? Because I see multiple septa here. And this particular thing is called finger in the glove sign. Aneurysmal bone cyst. Okay. Right. So please identify this tumor for me. And if you see anything else in the X-ray, do let me know. First identify what is this tumor and then the finding which you see. Any one of you? This is definitely a tumor. Dr. Rituraj-ji, that was very, very smart. Osteoid. So just tell me whether it is a benign one or a malignant one. And you people are very smart, I know that. Now see buddy here. If you open your notes and read about osteosarcoma. Those of you who are saying osteoid osteoma, it is seen at diaphysis. It is not seen at metaphysis. See, D means diaphysis, M means metaphysis, E means epiphysis. So osteoid osteoma, it is seen at diaphysis. Fine, I'll tell you the locations and how to remember them. Now, if you see buddy, if you read about osteosarcoma, read in your notes that it is a bone forming tumor. Osteosarcoma, most common primary malignant bone tumor, osteosarcoma. Right? Now, so this tumor arises from metaphysis. So what is this? This is osteosarcoma. Now what it will do? It will lift up the periosteum. And below the periosteum, a triangular structure forms. triangular structure forms. So what you see over here is called Codman triangle. Is called Codman triangle. Codman triangle. So that's a malignant tumor, osteosarcoma. Similarly here also, this tumor is arising from metaphysis. So this is also osteosarcoma. This is also osteosarcoma. So Codman triangle. This is what you get to see over here. Codman triangle. So you see that the periosteum is lifted up. Codman triangle. Codman triangle. Right? So make sure you look at this. This was, this particular question was asked in this year NEET PG. This year NEET PG, which has just happened. Fine. This particular question was very well there about the Codman triangle. 2 sessions were there. In one of the session they asked onion peel. In the other session they asked about Codman triangle. Okay. Now there are 2 images here again. Right. So in the first one, you see a periosteal reaction which is different from the other. So in the first one, you see sunburst appearance, while in the second one, again you see Codman triangle. So first one is sunburst, sun ray, hair on end, whatever you want to call, all of these are correct. Sunburst, sun ray, hair on end, all are same. Okay, and in the second image you again see that the periosteum is lifted, and buddies, below the periosteum again you see that there is a triangular structure. So that is called as Codman triangle. Codman triangle. Okay, Codman triangle. Adamantium affects the tibial diaphysis. Now, what do you get to see over here? So the first one here, buddies, is an X-ray image, and the second one is MRI image. T2 MRI image. T2 MRI image. Right? So what you see over here in both of that, in both the images, see here, this is first image, this is second image. So both is onion peel appearance, or what you can see, onion skin appearance. So both of them are showing onion peel appearance. Onion peel appearance. Since we see it at diaphysis, so this one is going to be Ewing's sarcoma. Since the tumor is at diaphysis, it will be Ewing sarcoma. Right? Ewing sarcoma. Chicken wire calcification. See, buddies, chicken wire calcification, this question is not important for MO exam, this question is not important for FMG, but this question is very important for NEET PG. So chicken wire calcification is pathognomic, confirmatory of chondroblastoma. Confirmatory of chondroblastoma, and this is not seen on X-ray, this is seen on biopsy. Chicken wire calcification. Chicken wire calcification. Dr. Shivani, see, in the first paper of NEET PG this time, they ask Ewing sarcoma, and then biopsy did show Ewing sarcoma, and X-ray did show Codman triangle. So just remember one thing. I want kind attention of everyone, please. Just remember one thing. Ewing sarcoma, most commonly it will cause onion peel, but it can cause Codman triangle, sunburst also. Okay. Osteosarcoma commonly causes sunburst appearance. Rarely Codman triangle, but it can cause onion peel appearance also. Fine. right? So this is pathognomic of chondroblastoma. That's one thing. Now we move to the next x-rays there. Now we will see some of the spine x-rays very quickly. Now this is a very common, all the question paper of all the institute, they have this image. Dr. Shivani, we keep on watching all the images. We'll keep on watching the images time and again. Then you will be able to differentiate. That's very simple, buddy. See, let's say, okay. Let's say this is bone, right? So sunburst appearance would be like this. Codman triangle would be like this. This is Codman triangle. This is sunburst appearance. You'll be able to see them. Don't worry. If I ask you again, you will be able to answer. Okay, right, buddies. So what you see over here, you see a white line in the middle. So this one is dagger sign. Now this is seen in ankylosing spondylitis due to calcification of intra and supraspinous ligament. Right, ankylosing spondylitis. What do you get to see? Dagger sign. Okay, now can anyone tell me what do we get to see over here in this condition, in this x-ray? So you see all the vertebrae are fused with each other. So what we get to see is called as bamboo sign. Bamboo sign. Here you see bamboo sign. All vertebrae, they fuse with each other. All vertebrae, they fuse with each other. Okay, I'll zoom up. Now, what do you get to see over here? यहाँ पे भी bamboo spine तो है, but there is something which you see over here. So, what you see over here is typically called as squaring of vertebra. Squaring of vertebra. So squaring of vertebra is also seen in ankylosing spondylitis. Squaring of vertebra is also seen in ankylosing spondylitis. Now see, buddy, let me zoom up. See, this one is a normal vertebra because it is curved inside. This one is also normal. Now see here, it is straight. It is absolutely straight. Picture frame vertebra, it is seen in Paget disease. I'll show you that also. Don't worry. Anything you speak in orthopedics, I'll try to show. Okay. So this is squaring of vertebra. अपने डॉक्टर कौन साहब थे? डॉक्टर रोहित जी जो MO वाला एग्जाम दे रहे हैं, who is appearing for the MO exam. Now he says that in MO exam, Rajasthan medical officer exam, they asked lot of one-liners. Okay. So there is another common one-liner that squaring of patella is seen in which condition? Squaring of patella is seen in hemophilia. Squaring of patella is seen in hemophilia. Right? So this is a one-liner question. Squaring of patella is seen in hemophilia. Squaring of vertebra is seen in ankylosing spondylitis. It is seen in ankylosing spondylitis. Right? Okay. Now, what do you get to see over here? So, if you see two bright white lines on the side, and no line in the center, no white line in the center, that is called as railroad sign. That is called as railroad sign. Like the tracks of railway की पटरियों जैसा, ट्रेन की पटरियों जैसा. right? Railroad sign. Now here, what you see is something different. You see two white lines on the side, and you see a white line in the middle also. You see a white line in the middle also. Now, this particular thing is called as trolley track sign, trolley track sign, trolley track sign, and they are also seen in ankylosing spondylitis, right? See here. Sorry. So if you see two white lines on the side and no line in the middle, this is going to be railroad sign. If you just see a white line in the middle, dagger sign, and if you see them both in the center as well as on the side, that is going to be trolley track sign, and all of them are seen in ankylosing spondylitis. Okay, it is common in males, it is common in young males 15 to 25 years of age. It is associated with HLA-B27. Now, can anyone identify this fracture? I'll zoom up. Please do identify this fracture for me. I'll not waste your time. I'll just wait for 15-20 seconds and then I'll quickly move. So this fracture occurred to a 26-year-old man who was wearing seat belts. It's too loud. You know, Dr. 𝗧𝗵𝗶𝗀𝗀, it is not the mic which is too loud. Actually, I am too loud. It's not the mic which is too loud. I am too loud actually. You know, I have been married for a good 15-20 years, so I rarely get to speak. That's why whenever I get to speak, I speak loudly. Right. So, no. This is not called seatbelt fracture. No. It is not hangman fracture at all. So, this is called as chance fracture. This is called as chance fracture. Fine. Now, this is also called as jackknife fracture. Also called as, no, it is not a whiplash. It is not a whiplash. It is not a seatbelt fracture. I mean, you can call it seatbelt fracture, but not a whiplash fracture. Certainly not a whiplash fracture. Fine. So, this occurs with flexion of spine. Flexion of spine caused by seat belt. Now, this is highly unstable. This is highly unstable fracture. Why is this unstable? Because you see, buddy, here, anterior part of spine fractured, posterior part of spine fractured, middle part of spine fractured. So spine is literally broken into two. Spine is literally broken into two. Once again, anterior part fractured, middle part fractured, posterior part fractured. Extremely unstable injury. Extremely unstable injury. Here, anterior fractured, middle fractured, posterior fractured. Okay. Chance fracture, also called as jackknife fracture, occurs with the use of seat belt. Other fractures with seat belt. Can any one of you please tell me other fractures which occur with the use of seat belt? Anterior rib fractures affecting 4th to 7th rib. Anterior rib fracture. So they also occur commonly with the use of seat belt. Fine. Anterior rib fracture. Okay. Now here, 𝗧𝗵𝗃𝗀 fracture. Here you see this fracture is going to affect C6 or C7 vertebra. 𝗧𝗵𝗃𝗀 fracture. 𝗧𝗵𝗃𝗀 fracture. Right, buddies? 𝗧𝗵𝗃𝗀 fracture C6 or C7 vertebra. Posterior aspect, that means the spinous process. Similar post-mortem fracture, that means it will be seen in dead patients. So similar post-mortem fracture after death, you see that is undertaker fracture. Let's say unfortunately someone dies and they are going to bury the body. Now if the body falls in the grave, कब्र में अगर body गिर गई, so this part will strike the ground. This part will strike the ground and there will be a fracture. So basically 𝗧𝗵𝗶𝘀 and undertaker are similar, but this will be seen in alive patient, this will be seen in dead patient, right? Post-mortem finding it is undertaker fracture. But what you see over here is 𝗧𝗵𝗶𝘀 fracture. Okay, then Jefferson fracture. So Jefferson fracture is burst fracture. How can burst fracture occur? Like this. So if your patient falls like this on the ground, if your patient falls like this on the ground, fine, burst fracture of atlas. Now here what is present? SC means the spinal cord. No, Dr. Puneet, it has got nothing to do with the wrestler. It has got nothing to do with the wrestler. So this is the spinal cord, right? So see, this is the spinal cord. What happens if there is Jefferson fracture? Bone is divided into multiple fragments and all the fragments, they fly outside. All the fragments, they fly outside. Spinal cord is not injured. Spinal cord is not injured, right? So burst fracture of atlas. Burst fracture of atlas. Burst fracture of atlas. So there is generally no neurological deficit. Now what do we need? We need open mouth odontoid view. So this is open mouth odontoid view to see this fracture. Yes, exactly. Yes, exactly. Fall from height. Fall from height. Right? So this is open mouth odontoid view. Right? Now, somebody just mentioned about the hangman fracture. This is the hangman fracture. So hangman fracture is going to affect C2 vertebra. C2 vertebra. Axis vertebra. Hangman fracture. Hangman fracture. So technically speaking, what happens in hangman fracture? C2 vertebra will slip forward over C3 and C2 vertebra will break. C2 vertebra will break. Hangman fracture. Hangman fracture. Right? This is how it might occur. Hangman fracture. This is how it occurs. So this is C2 slipping over C3 plus there is fracture of C2. Now this term technically speaking is spondylolisthesis. Spondylolisthesis. Now this might occur with forced hyperextension of neck. This might occur with forced hyperextension of neck. Might occur with forced hyperextension of neck. What is being shown here? Forced hyperextension of neck. मतलब सीट बेल्ट पहनो तो चांस फ्रैक्चर, नहीं पहनो तो ये वाला फ्रैक्चर. बंदा करे तो क्या करे? Right? You see here. So spondylolysis. What is spondylolysis? Spondylolysis is stress fracture of pars inter articularis, right? And spondylolisthesis is complete fracture. It is complete fracture plus slippage. Complete fracture plus slippage. Fine. So you see there are similar sounding terms. For example, if it is written like spondylosis, it just means something is wrong with the spine. It could be fracture, it could be infection, it could be arthritis. Fine. So spondylosis, it is an umbrella term. This is first term. Second term is spondylolysis, that is stress fracture. Third term is spondylolisthesis, complete fracture. Fourth term is spondylitis, that means inflammation, of the spine. So these all four are similar sounding terms. Okay, now see here. So what you see over here, that there is spondylolysis. So most commonly it is seen between L5 to S1 in case of trauma, and it is seen between L4 to L5 in case of OA, means osteoarthritis. Now what do we get to see on X-ray lateral view? Broken neck of Scotty dog. This is also called as collared Scotty dog, Fine. Now this is also known as Scottish Terrier sign. Make no mistake, Scotty dog appearance is seen in the normal spine, but broken neck of Scotty dog, it is seen in spondylolisthesis. Right? मोहित जी, ये जो आप कह रहे थे कि वन लाइनर है, मोस्ट कॉमनली बिटवीन L5 to S1. Now, when you take AP view, antero-posterior view, but is what do you get to see? You get to see something which is called as inverted Napoleon hat, sign. So this is Napoleon hat. This is inverted Napoleon hat. So this is how the Napoleon hat looks like. Inverted Napoleon hat sign. Inverted Napoleon hat sign, it is seen in spondylolisthesis. On AP view of X-ray, anterior-posterior view of X-ray, right? Now see, this is inverted Napoleon hat, right buddies? I'll write it over here. Inverted Napoleon hat. Okay G, let's move forward. Now here, so if you get to see something like this, bright white thing which you see, so what is that? That is sclerotic, or you can call it blastic metastasis in bone. And what is the mnemonic? PCM. So it is seen in prostate cancer, it is seen in carcinoid tumor, it is seen in medullary carcinoma of thyroid, medullary carcinoma of thyroid. Naman ji, मैंने लिख भी दिया, I wrote it that I will share the PDF 110%. Why are you guys after the PDF यार all the time? What do I do with the PDF? मैं PDF को रख के क्या करूंगा? मेरे लैपटॉप में और अच्छी अच्छी चीजें हैं. Right here. So here what do you get to see? You get to see something which is called as winking owl sign. Winking owl sign. So winking owl sign, it is seen in lytic metastasis. Lytic metastasis. Fine. Lytic metastasis. Here you see the vertebra is destroyed. Lytic metastasis. Not this. Not this. Here you see lytic metastasis. So if you can see blind winking owl sign like this. So these vertebra are normal, but this vertebra has got tumor. There is no eye over here. Lytic metastasis. Lytic metastasis. So where do you get to see lytic metastasis? So lytic metastasis are typically seen in follicular carcinoma of thyroid. Dr. Namaji, my regrets. Okay, follicular carcinoma of thyroid, and they are also seen in renal cell carcinoma. They are also seen in renal cell carcinoma. Right? So winking owl sign. So buddies, what happens here? That let me erase them. See. So when you take normal X-ray of spine, you get to see the pedicles like this. So they look like eyes of owl. First eye, second eye. Here. So these vertebrae A, B and C. So A and C, perfectly normal vertebrae. But here what has happened, that in this area a tumor is there. It has destroyed the bone. It has destroyed the bone. Now, as of now, the tumor is up to this point. This is the tumor. Suppose the tumor destroys other part also. Suppose the tumor destroy other part also. This is called as blind bat sign. Blind bat sign. So lytic metastasis on one side, that is winking owl sign. If it is on both sides, that is called as blind bat sign. So blind bat sign is lytic metastasis. Lytic metastasis on both sides. Lytic metastasis on both sides. Blind bat sign. Right? Blind bat sign. Now this basically what has happened, that vertebral body is damaged. Vertebral body is damaged. So this patient is suffering from tuberculosis. Why is this so? Why is this so? So you see, there is a rule. There is a rule that tuberculosis will affect anterior part of spine and tumor will affect posterior part of spine. Now what you see over here, see like this. So this is winking owl sign. Winking owl sign. Winking owl sign. It is seen in lytic metastasis. Lytic metastasis. Right? Winking owl sign. Okay. Now these are the flag signs of backache. Again buddies, this is a NEET PG PYQ. This is a NEET PG PYQ. Red flag sign. Red flag sign means the backache is not normal. The patient comes to you, doctor, I am having back pain. Oh, no problem. Take some painkiller, the pain will go away. But if your patient has these things, that means the back pain is going to be serious. The back pain is not normal. Okay, if it occurs in young patient, why should a young patient have back pain? So young patient back pain could be because of tumor. Okay, then if age more than 50 years, this could also be due to tumor. This could also be due to tumor. If there are sphincter disturbances, that means the spinal cord is being compressed. That means the spinal cord is being compressed. Okay, same for perianal sensory loss. Cachexia. Now cachexia means patient doesn't feel like eating, is losing weight. This could be because of TB or tumor. Again, radiculopathy. That also means that pain is going to the limbs. Red flag sign. So these are like important ones. Okay, red flag signs. Then buddies, we have got yellow flag signs. Yellow flag sign. Yellow flag sign means there is increased risk of chronic pain. There is increased risk of chronic pain or disability. Disability. Social isolation. Patient does not go to parties because of back pain. Emotional withdrawal. Every time, every hour, every minute, patient is just thinking about back pain. Fine. Anhedonia. His back pain is so severe that he cannot experience pleasure. Fine. Psychological withdrawal. He is just thinking about back pain and nothing else. Because of that, he is drinking alcohol, taking steroids, and has taken 4 weeks leave from office. So this is important for NEET PG. Red flag sign. Buddy, Dr. G, this cachexia means patient doesn't feel like eating, is vomiting, retching all the time and losing weight. So anorexia is one term. Cachexia is an umbrella term. Patient is having anorexia, nausea, vomiting, retching and losing weight. Cachexia, right? Okay. Okay. Now the important x-rays of upper limb. Important x-rays of upper limb, right? Now the clavicle. Remember, clavicle is the most commonly fractured bone overall in newborn at the time of delivery. Now why is this bone so commonly fractured? Because you see, medial 2/3 is cylindrical and lateral 1/3 is flat. That is why the junction is the weakest point. Okay. Now in clavicle, what do they ask is that what is the treatment? What is the treatment if the fracture occurs? So buddies, if the fracture is unilateral, if the fracture is undisplaced, in that case the treatment is triangular arm sling. If the fracture is bilateral, if the fracture is displaced, we will be using figure of 8 brace. Figure of 8 brace. We don't use bandage, but we use brace. Okay. Now, what are the indications of surgery? When to do surgery? So if there is fracture at lateral or even medial end, in that case we will do surgery. Now if it is associated with floating shoulder, this is important for NEET PG. So what? There is fracture of clavicle plus there is shoulder dislocation plus there is fracture of glenoid, that is floating shoulder. If there is neurovascular injury, and then cosmetic indication. For example, there is overlap more than 2 centimeter. So this is clavicle. Suppose the clavicle is broken into 2 fragments, and one fragment goes like this. So this is overlap. This is overlap. Now, if this overlap is more than 2 centimeter, you will do surgery. Fine. Surgery is also done if it is an open fracture. If this is an open fracture, then also we will do surgery. Okay. Right. Then fracture proximal humerus. Fracture proximal humerus. Fracture proximal humerus. Right. Now they ask you which is the most common site of fracture. So most common site of fracture is cervical neck. Cervical neck of humerus. Cervical neck of humerus. This year in NEET PG they asked Gartland classification, right? So I am sure that they might ask Neer classification. Neer classification. Dr. Anirudh-ji, Dr. Shivani-ji, there are 2 necks of humerus: anatomical neck and surgical neck. So most commonly it affects the surgical neck. Okay ji. Now Neer classification. Neer classification, it is used for humerus, proximal humerus, right? So let's say if the bone is broken into 3 parts but all of them are together, this will be called as one part fracture. One part fracture. You don't need to do surgery. You will be using triangular arm sling. If the bone is broken into 2 parts, this is called as 2-part fracture. Again, you don't need to do surgery. Closed reduction is the treatment. If the bone is broken into 3 parts, now you will have to do surgery. But if the bone is broken into 3 parts, you cannot fix it. Now you will have to do the joint replacement, hemiarthroplasty. Now you will have to do hemiarthroplasty. Right? Hemiarthroplasty. They don't ask so much detail, but we must remember this. Right? Most common site is cervical neck of humerus. Now again, this point which I am going to make is important only and only for NEET PG. Now buddies, see, this is insertion of deltoid. If the fracture is proximal, what will happen? What will happen to the proximal fragment? What will happen to the proximal fragment? Right? Let me write it very quickly. So, if the fracture is proximal to the deltoid insertion, what happens is that proximal fragment is adducted. Proximal fragment is adducted. Fine. Proximal fragment is adducted. Okay. Second thing here, you see, this is insertion of deltoid and the fracture is like this. Fracture is below. So if fracture is distal to deltoid insertion, what happens to the proximal fragment now? See, the proximal fragment will be abducted. Proximal fragment will be abducted. Proximal fragment abducted. Again, only and only important for NEET PG, right? Okay, we'll continue. Now, this is Holston-Lewis fracture. Holston-Lewis fracture. So, Holston-Lewis fracture. Holston-Lewis fracture, that is fracture of proximal 2/3 and distal 1/3 junction. Which bone? Humerus. Plus there is radial nerve injury. Plus there is radial nerve injury like this. So radial nerve will be moving here like this, and it is commonly injured. Radial nerve injury. Now this is a mnemonic here. This is the mnemonic for upper limb injuries. This is the mnemonic for upper limb injuries. Mnemonic. Sorry, mnemonic ban gaya tha. So this is a mnemonic. If proximal humerus is fractured, axillary nerve is injured. If mid humerus is fractured, radial nerve. And if distal humerus is fractured, median nerve is injured. Median nerve is injured. Right, buddies? That's a mnemonic here to remember which nerves are injured. Holston-Lewis fracture. Now, in Holston-Lewis fracture, to treat the radial nerve injury, we will be using this one. 1 and 2. So we will be using dynamic cock-up splint. Dynamic cock-up splint is used for radial nerve injury. Make sure, buddies, you don't confuse it with knuckle bender splint. Make sure you don't confuse it. Don't ever confuse it with knuckle bender splint. Knuckle bender splint is used for ulnar nerve injury. It is used for ulnar nerve injury. Very good, Dr. Anirudh. So this is dynamic cock-up splint. Why dynamic? Because it has got springs. It has got springs. That is why dynamic cock-up splint. Yes. Exactly, Dr. Puneet. Now, supracondylar fracture of humerus. Supracondylar fracture of humerus. So it is all about 3 bony points. Lateral condyle, medial condyle, and olecranon. Right? Lateral condyle, medial condyle, and olecranon. Like this. Lateral condyle, medial condyle, and olecranon. Fine? 3 bony points. So these 3 bony points, when the elbow is flexed, they form a triangle like this. When the elbow is flexed, they will form a triangle. But when the elbow is straightened, extended, they will form a straight line. They will form a straight line. Now that is the normal arrangement. That is the normal arrangement. Now 3 bony point relation will be altered, will be changed in lateral and medial condyle of humerus fracture. Right? But the fracture which we are going to study is this supracondylar fracture of humerus. So here in supracondylar fracture of humerus, 3 bony point relation is not altered. 3 bony point relation is not altered. Okay. Now here, most of the fractures, they are extension type. Most of the fracture, they are extension type. What is the mechanism? The mechanism is 𝗵𝗃, fall on the outstretched hand, fall on the outstretched hand. Now this is Gartland classification. So in NEET PG paper this time, in the first morning session, they asked this Gartland classification. Gartland classification. 𝗵𝗃's fall on the outstretched hand. So this is a PYQ. They asked this here only. Gartland classification. What they did ask was this type 3. So you see in type 3 it is a complete fracture, complete displacement, right? Complete displacement. Okay, so first you see just a fracture. Second, you see here in the type 2, you see posterior cortex is still okay and there is some angulation. In type 3 there is complete displacement. So that's a PYQ. You people are always fond of PYQ, right? So Gartland classification. Now this is fishtail sign. Fishtail sign. If you can see the fishtail, so this is fishtail sign. So where do you get to see fishtail sign? But is fishtail sign, it is seen in displaced fracture. Displaced basically means rotated fracture. Displaced fracture. Fishtail sign. So this is how a fishtail looks like, and this is how the bone looks like. This is how the bone looks like. Fishtail fracture or fishtail sign, right? Displaced fracture. Okay. Now, so what are the clinical features of this fracture? S-shaped deformity. S-shaped deformity, and then dimple sign. Dimple sign. So as you can see, dimple sign. Okay. So proximal fragment will call a dent on the skin. Dimple sign. Right. The nerves are commonly injured. Anterior interosseous nerve, which is a branch of median nerve. How will you identify? Ask the patient to make OK sign. So normal patient will make it like this. Flexion, again flexion. So normal patient. But if there is anterior interosseous nerve injury, flexion here, but there will be no flexion. There will be no flexion. Anterior interosseous nerve injury. Abnormal OK sign. Right? So this occurs due to paresis of flexor digitorum profundus and flexor pollicis longus. Right? So name of the muscles, they are important only for NEET PG. Right? Then benediction hand. So benediction hand, patient will not be able to flex these fingers like this. Hand will remain like this. Hand will remain like this. Right? Benediction hand. Now, this particular thing, this particular deformity is seen in median nerve injury. That is called as 𝗵𝗶𝗀 sign. 𝗵𝗶𝗀 sign. So, what is 𝗵𝗶𝗀? Thumb is close to rest of the hand. Thumb is close to rest of the hand. Now, this is also seen in median nerve injury. Also seen in median nerve injury. Because many of you confuse it with claw hand. So this finger is absolutely normal. Absolutely normal. This is the finger which is affected. Finger which is affected in the median nerve injury. Right? Now, your patient may develop brachial artery injury. Your patient may develop brachial artery injury. Brachial artery injury will cause Volkmann ischemia. Volkmann ischemia will cause Volkmann ischemic contracture. Will cause Volkmann ischemic contracture. Volkmann ischemic contracture. Right now, this is the image which is going to show you Volkmann ischemic contracture. Volkmann ischemic contracture. Now this is treated with the help of turnbuckle splint. Make sure you don't make this mistake. There is another device called as turnbuckle cast. So this image is showing you turnbuckle cast. Turnbuckle cast is used for scoliosis. How do you differentiate? Cast is 360-degree coverage, whereas splint is less than 360-degree coverage. 360-degree coverage, right? So the name is same, turnbuckle, but other thing is different. Turnbuckle cast, and what we use in Volkmann ischemic contracture is turnbuckle splint. Turnbuckle splint. Okay. Now, here you see in scoliosis. Scoliosis is sidewise bending of spine. So we use an angle. That angle is called Cobb angle. So there are different named angles. Mohit, again these are one-liners, important both for NEET PG and FMG. Kite angle is seen in club foot. Bowman angle in elbow fracture. Carrying angle is to check whether your patient has normal or abnormal elbow. Neck shaft angle is for 𝗧𝗵𝗶𝗀 and 𝗧𝗵𝗶𝗀. Q angle is to check if your patient has genu valgum or genu varus. So all of these are important one-liners. Okay. Coming back to the supracondylar fracture of humerus. So here the common complication is malunion, giving rise to gunstock deformity. Now, gunstock deformities, buddies, is cosmetic deformity. It just looks ugly. Otherwise, there is no problem. Otherwise, your patient is absolutely normal one, not a functional deformity. What exactly is the problem? Your patient has excessive cubitus varus. Your patient has excessive cubitus varus. What is the treatment? Treatment is modified French osteotomy. Modified French osteotomy. Right? Treatment is modified French osteotomy. Modified French osteotomy. Okay. I forgot to mention the treatment. Treatment of supracondylar fracture of humerus. I forgot to mention. So treatment is surgery. Always prefer surgery. In supracondylar fracture, buddies, cast is not used. Cast is not used. Why? Because there is high risk of compartment syndrome. There is very high risk of compartment syndrome. That is why cast is not used in the treatment of supracondylar fracture of humerus. We don't use cast at all. Right? Very rarely in some of the small children we use cast, but then it has to be observed. Patient has to be observed. French osteotomy, it is the treatment of gunstock deformity. It is the treatment of gunstock deformity, right? The treatment of gunstock deformity, right? Okay. This year NEET PG, Salter-Harris classification was also there. They did not ask any question on Salter-Harris classification, but it was there in one of the options. Now, few of you have already read this. Please tell me 𝗧𝗵𝗶𝗀 sign, it will be seen in which type? 1, 2, 3, 4. So fracture lateral condyle of humerus, it is an intra-articular fracture. Fine, because intra-articular fracture it is, so physis, that means growth plate is also injured. If the growth plate is injured, we use Salter-Harris classification. Salter-Harris classification is used. Salter-Harris classification is used. Salter-Harris classification is used. Fine. Now, the fracture is similar. Fracture is similar to type 4. Fine. Now this is where you will get to see 𝗧𝗪 sign. 𝗧𝗪 sign. So 𝗧𝗪 sign is like this. 𝗧𝗪 sign. 𝗧𝗪 sign is seen in type 2. 𝗧𝗪 sign is seen in type 2 fracture. It is seen in type 2 fracture. Now, coming to the lateral condyle of humerus fracture, common complication is non-union. Very, very important question, right? Now, it may also cause cubitus valgus deformity. Now, this point is only important for NEET PG. That means if they ask you a difficult question. Now, this fracture, lateral condyle of humerus fracture, is also associated with tardy ulnar nerve palsy. The word tardy means very, very slow. So, this develops after few years. Ulnar nerve palsy will develop after few years. It will not develop immediately. It will develop after few years. Okay. Yes, buddies. Can any one of you identify this fracture? Can any one of you identify this fracture, please? Can any one of you identify this fracture for me, please? So this is the fracture. Please name this fracture. Absolutely correct. This is a nightstick fracture because this joint is normal. This joint is normal. So what you see on your screen is nightstick fracture, which is also known as defense fracture. So what exactly is this, buddies? This is an isolated fracture of ulna. Isolated fracture of ulna. Isolated means that there is no other injury. No other injury. Okay. So what you get to see now is Monteggia fracture. So Monteggia fracture, there will be fracture of proximal ulna, plus there will be dislocation of radio-ulnar joint. Now as you can see over here, there is fracture of ulna, and then you can see there is dislocation. There is dislocation of radio-ulnar joint. There is dislocation of radio-ulnar joint, right? Monteggia fracture. Okay. Now same, there is fracture and there is dislocation. Okay. Now, so here you see, buddies, what has happened is that instead of ulna, now radius is fractured. And which radius? It is the distal radius which is fractured. And apart from that, there is also dislocation. So this fracture happens to be 𝗧𝗵𝗃 fracture. 𝗧𝗵𝗃 fracture is also known as reverse Monteggia fracture. So 𝗧𝗵𝗃 fracture is also known as reverse Monteggia fracture. So every year the audience, they do change. So please quickly allow me to use the previous mnemonic which I used 6 months ago, right? So you see the mnemonics. First is GFR, glomerular filtration rate. So that is one simple one, that 𝗧𝗵𝗃 fractures radius. Then the other mnemonic is MUGGER. So MUGGER means Monteggia will fracture ulna and 𝗧𝗵𝗃 will fracture radius. But I told you I developed my own mnemonic somewhere in the year 2019. So let's see if that mnemonic can help you. Now let's say here is your patient standing. Now these are the bones of his limbs, right? Now, okay, let me do it like this. Just give me a minute. Maybe I can help you out here. The technical team will not be very happy if I'm fiddling with the settings. Now let's say, buddies, I'm standing here. Now which bone is close to my body? Naturally, it is the ulna. Radius is away from my body. Ulna is close to my body, right? Radius is away. Now here, somewhere here must be my heart, right? So which part of ulna is close to my heart? Proximal part of ulna, right? Which bone is close to my heart? Ulna. Which bone is away from my heart? Radius, right? And which part of ulna is close to my heart? It is the proximal part, right? Okay. Now, so let me draw the two bones over here. Let's say this is ulna. Let's say this is the radius. Okay. Now somewhere here is the heart of your patient. Now this. So what happened was, I developed this mnemonic in the year 2019. Elections were held. Again, I am not a political person. I don't have any affiliation with any political party. This is just a mnemonic. Now Modi ji did won the election because he was close to the hearts of people, right? So which bone is close to the heart? Ulna. Which part of ulna? Proximal ulna. So here Monteggia, M for Monteggia, M for Modi ji. Fine. So that is why you see Monteggia fracture will affect proximal ulna, right? Now here, all his life Modi ji did politics against one family, G. G for Gandhi family. 𝗧𝗵𝗃 fracture. 𝗧𝗵𝗃 fracture will affect distal radius. Now somebody told one of the Gandhi that you too can become Prime Minister, be in the line. Fine. Which Gandhi is that? RG. Rahul Gandhi. Fine. So, reverse 𝗏𝗏𝗃 fracture. Reverse 𝗏𝗏𝗃 fracture will affect the distal ulna. Distal ulna, right? Hello, Dr. 𝗵𝗵𝗀𝗀𝗃. Okay, so this is the way to remember. This is the way to remember. Otherwise, you see there are so many other mnemonics. Grimus. Fine. What is this mnemonic all about? Now, again, 𝗏𝗏𝗃 fractures the radius at inferior location. Monteggia fractures ulna at superior location. At superior location. At superior location. So Grimus, that is one mnemonic. Okay, so there are so many mnemonics, as many mnemonics as you can remember. In last class, one of the student told me this very good mnemonic. That's our 𝗏𝗏𝗃. G for ground. Ground is below. So fracture will occur. So when the ad plays, I have to stop and wait for the ad to end. So when the ad plays, do I have to stop and wait for the ad to end? Okay, right. So he says G for 𝗏𝗏𝗃. 𝗏𝗏𝗃, ground is below. So fracture will occur below. Okay. M, Monteggia, moon. Moon is above. So fracture will occur above. Fine. That is a way to remember. Monteggia and 𝗏𝗏𝗃 fracture. Again, you know, what we see now here is Colles fracture. Colles fracture. Now, Colles fracture will occur because of 𝗬𝗓, fall on the outstretched hand in elderly. Fall on the outstretched hand in the elderly. Okay. Fall in the outstretched hand in the elderly. Colles fracture. Now, how do you identify all these different fractures? Find Colles fracture, Smith fracture. Let's see. Now, again, I want to change the settings very quickly, please. Right? Okay. Let me change the background also. You know, upper limb is a long topic, I believe. Right? Now, okay. Right, buddies, here. Now, see here. So, if I'm standing here like this, right, buddies? Now, you see my thumb is the lateral most finger. My little finger is the medial most finger. So, if I do like this, that is lateral deviation, also called as radial deviation. If I do like this, that is medial deviation, also called as ulnar deviation. Very quickly, a quick repetition. If I stand like this, my finger, first finger is the thumb, which is close to the radius bone. Close to the radius bone. Okay, so if my fingers, they go like this, this is radial deviation. If my fingers, they go like this, this is ulnar deviation. Very quickly, yet again. Normal position. Lateral deviation, also called as radial deviation. Normal position. Medial deviation, also called as ulnar deviation. Right, buddies? Okay, here. Neutral position. Okay. But first, you see this. Whatever you see right now, that is called as anterior, ventral, volar, flexor aspect. And what you see, this is palmar aspect. Right, buddies? Anterior ventral volar flexor aspect. What you see now, dorsal extensor posterior aspect. Very quickly, anterior ventral volar palmar, okay, dorsal extensor posterior aspect. Okay, buddies? Now look at my hands, neutral position. If they go like this is called as flexion or palmar flexion. Neutral position. If they go like this is called as extension or dorsiflexion. Extension or dorsiflexion. Right, buddies? Very quickly, please allow me to repeat. Neutral position, flexion, also called as palmar flexion. Neutral position, extension, also called as dorsiflexion. Right? Okay. So about these movement, these positions, because you know in 𝗧𝗵𝗃 fracture they are absolutely necessary. Now, so 𝗧𝗵𝗃 fracture, it occurs due to 𝗵𝗃, fall on the outstretched hands. Right? Now, remember, 𝗧𝗵𝗃 fracture is an extra-articular fracture. Your patient will fall like this. Right? Okay. Now, so clinical feature will be slip. Slip means supination, lateral angulation of fingers, impaction, and P means posterior displacement. And the treatment of 𝗧𝗵𝗃 fracture, treatment of 𝗧𝗵𝗃 fracture is handshake cast. Now this has to be done in propaganda. That means from supination we will do pronation, then palmar angulation, and from lateral angulation we will do ulnar deviation. Ulnar deviation. कार्तिक साहब मुझे इसका आइडिया नहीं है जी. Right? Slip. Okay. Now, Smith fracture is due to fall on the inward turned hands. Right? So in Smith fracture, everything is reverse. In the Smith fracture, everything is opposite. In Smith fracture, clinical feature will be propaganda and treatment would be slip. Right? So dinner-fork deformity, that is complication. Dinner-fork deformity is complication of 𝗧𝗵𝗃 fracture. So what it is basically, this is a malunion, and this is very disabling deformity, disabling deformity. Patient will not be able to do any work normally. So what is the treatment? Treatment is 𝗧𝗵𝗃 operation. Important for NEET PG. 𝗧𝗵𝗃 operation. Smith fracture, what is the complication? Again, complication is malunion. Again, complication is malunion, which will give rise to garden spade deformity. Again, this will give rise to garden spade deformity, right? Now buddies, before we can read the different type of fractures, let me write one line where the students commonly make mistake. Let's see if you do make the mistake or not. If they ask you what is the most common complication, if they ask you what is the most common complication of Colles fracture, what will your answer be? Answer is not malunion, answer is not dinner fork deformity, answer is finger stiffness, finger stiffness. Apart from dinner fork deformity, what is another complication? Another complication is rupture of extensor pollicis longus tendon. Extensor pollicis longus tendon. Very good, Dr. Rishabh-ji, Dr. Bhagath-ji, good evening. Okay, now I believe we can see the Barton fracture. First of all, buddies, Colles and Smith. Colles and Smith, what are they? They are extra articular fracture, whereas Barton, it is intra-articular. Barton, it is intra-articular. Let us understand this thing with the help of this image which I have taken from Radiopedia, right? Very quickly. See. Okay, so buddies, this is the joint, right? And here, this is the fracture line. That means it is an extra articular fracture. Extra articular fracture, plus you see buddies here, there is dorsal angulation. Dorsal angulation. That means it is Colles fracture. Colles fracture. Next, this is the joint, wrist joint. Which joint? Wrist joint. And this is the fracture line. This is the fracture line, right buddies? Now here, that means it is intra-articular fracture, plus you see there is dorsal angulation. There is dorsal angulation. So because the fracture is intra-articular, this is dorsal Barton fracture. Dorsal Barton fracture. I want to show you two more images. So we'll take a break in around 5-10 minutes. We'll take a small 10 minutes break in 5-10 minutes. I want to finish the one. So after we are done with upper limb, we'll take a small break of 5-10 minutes. Okay. Now see, again this is the joint and this is fracture, right? And now your patient has volar angulation. Volar means anterior angulation, and the fracture is extra articular. Fracture is extra articular. So this is Smith fracture. Looking at the fourth image, see buddies, this is the joint and this is fracture. Okay, so this is intra-articular fracture. Intra-articular fracture, plus there is volar angulation. Volar means anterior, like this, anterior angulation. So this is reverse button, also called as volar button, also called as volar button. So please don't make this mistake, right? Please don't make this mistake to differentiate between button and reverse button. Okay, I'll draw a table also after 1 or 2 minutes. Now, so if there is fracture of styloid process of radius, that means the lateral side of radius, if there is fracture, that fracture is called as Schoffer fracture, also called as Hutchison fracture. Similarly, if you can see here, there is a fracture here at the medial end. So if there is fracture of medial aspect of radius, now this fracture is called die punch fracture. This is called as die punch fracture of the medial aspect. So you see, if you compare both of them, here see buddies, the lateral aspect is fractured. Here you see the medial aspect is fractured, right? So Schoffer fracture and Schoffer fracture and die punch fracture, right? So you see here, this handle will fall on the hand of patient, and this will cause Schoffer fracture. And then if the fracture does not occur on lateral side but it occurs on medial side, this will be called as die punch fracture. Yeah, TB hip also there is a question, because that is the most common peripheral joint affected by tuberculosis, right? Okay, Dr. Kuldeep Singh Chaudhary साहब ने एक पॉइंट रेज किया कि there is always a question on TB hip. मैंने आंसर दिया yes, most common peripheral joint affected by tuberculosis is hip. 2 years back there was a question, what is the initial site of tuberculosis in hip joint? Anyone, can you answer? What is the initial site of tuberculosis in hip joint? I'll write the answers, but see, so this can be asked as an image based question. Lunate dislocation, this is seen in lunate dislocation. No, Dr. Rituraj, let's focus on this. I'll answer that now. So what we get to see, spilled teacup sign. Remember, lunate is the most common carpal bone, to undergo dislocation. Yes, Dr. Maruti. Dr. Maruti gave the right answer, acetabulum. If I make the question difficult, Dr. Maruti, I'm sure you'll still be able to answer. What is the earliest sign in the femur? What is the earliest site in femur? Earliest site of tuberculosis in femur. Earliest site of tuberculosis in femur. Let me answer these. Very good. Now you have upped the game actually. So in tuberculosis of hip, earliest is seen at acetabulum and in the femur head, it is seen at Babcock triangle. Babcock triangle. Babcock triangle. So both these questions have been asked in the past, right? Tuberculosis of the hip. Hip is most common peripheral joint affected by TB. Affected by TB, right? Both these questions have been asked in the past. Okay, Ji. Now here. So let's say the ulnar collateral ligament is injured like this. Ulnar collateral ligament is injured. That will be called as skier thumb. So skier thumb is acute injury. Then gamekeeper thumb is chronic injury to ulnar collateral ligament. Chronic injury to ulnar collateral ligament. Okay. Then fracture of the scaphoid. Now scaphoid is the most common carpal bone to get fractured. One liner. Mechanism is 𝗓𝗄, fall on the outstretched hand in young. Now I hope you know this already, that 𝗓𝗄, if it occurs in children, it is going to cause supracondylar fracture of humerus, right? If it occurs in young, it will cause scaphoid fracture. If it occurs in elderly, it is going to cause Colles fracture. 𝗓𝗄, fall on the outstretched hand. Clinical feature fullness in the anatomical snuff box. Investigation of choice is MRI. Treatment is immobilization in the glass holding cast. How will you identify glass holding cast? Thumb is always covered. Most common site of fracture is waist of scaphoid, whereas in children most common site is distal pole. If the fracture is displaced, we will be using Herbert's screw, and we of course will have to do surgery. Right here, what you see, base of thumb is broken into two fragments. So that is Bennett fracture. Bennett fracture. I read it from some Instagram group that Bennett, you see B for bi, and bi means two. So Bennett means two fragments, and this is displaced fracture. Another thing given in that Instagram group was RRR. So 1, 2, 3. RRR was a movie. So if it is Rolando fracture, there will be minimum 3 fragments. Minimum 3 fragments. Right? Rolando fracture and Bennett fracture both occur at same site. But if there are 3 fragments, that is comminuted, it is Rolando. If there are 2 fractures or 2 fragments, it is Bennett. Right, G? Now, here, fracture of 5th metacarpal neck, boxer fracture. Boxer fracture. Yes, exactly. Dr. Kuldeep Singh Ji, exactly. So it occurs in advanced stage. So this is the treatment of boxer fracture. So again, what is important here, the image, ulnar gutter split. Syndactyly, fusion of fingers. Syndactyly means fusion of fingers. So So most commonly it is seen between middle and ring fingers. Middle and ring fingers. Middle and ring fingers. MRF is the mnemonic. Right? Polydactyly. So most common is your patient will have two or more than two thumbs, like Hrithik Roshan, the famous movie star. He has got two thumbs, polydactyly. Fine. One or two extra fingers. So this one happens to be the most common. Then mallet finger is rupture of extensor tendon. Rupture of extensor tendon. Mallet finger, buddies, is also called as baseball finger. Is also called as baseball finger. Is also called as baseball finger. Mallet finger, rupture of extensor tendon. What is the treatment? The preferred treatment is surgery, or we can use 𝗧𝗵𝗶𝗀 splint. You can use 𝗧𝗵𝗶𝗀 splint. So this is 𝗧𝗵𝗶𝗀 splint, right? Then the opposite one. What is the opposite one? Opposite one is jersey finger, which is also known as rugby finger. Now that is injury to flexor tendon. There also the treatment is repair, or you will be using frog splint. So frog splint, there will be flexion. Right? So all the important upper limb topics have been covered, right? I mean, it is very easy to do blah 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 while you are sitting on this side of the chair. I absolutely know that. Fine. Thank you so much for your patience. Fine. You have been very, very lovely audience as of now, right? I mean, as of now. After that, maybe you might become angry, right? So we will take a 15-minute break as of now. And sharp after 15 minutes, we'll assemble. Let me convey you the exact time. Please adjust your watches. So as of now, it is like 2148 at my watch. So okay, we'll assemble at 10:05 p.m. Right? We'll assemble. Yes, Kuldeep Singh ji. PDF pakka mujhe malum hai. So we'll assemble at 10:05. Please be there. We have to read the conceptual part. We have to read. We have to see splints and instruments. Fine. This is all we have to read. The instrument part is the next coming up. Then we'll see the important topics also. Right? 15 minutes break as of now, and we'll assemble again. Alright buddies, kindly allow me to start and do let me know if I'm audible and visible. Please do let me know if I'm audible and visible. Right, thank you. So you'll have to identify different instrument. So if you see, there are two sharp edges in this instrument, and this happens to be a heavy instrument. So what is this? Osteotome. So it is used to cut the bone, osteotome, right? Then this is also used to cut the bone. So this is giggly saw, like this. We'll cut the bone, giggly saw. Okay. Now, this instrument is periosteal elevator, and this one is bone cutter, rib cutter, bone cutter, whatever you want to call it, right? So you see, these are also rib cutter. Nibbler usually has got a curved edge like this. Nibbler usually has a curved edge like this. Nibbler, small edge, right? So we prefer to call it cutter. So these are like Steinman pins. Kirschner wires, they are also the same but comparatively thin, right? Steinman pin. These are like Crutchfield tongs, right? Now here, these three things are very, very important. Okay, so if you see two holes, so what is that? This one is Austin Moore. Two hole in the name also. Austin Moores. If there are absolutely no holes, this one is Thompson. And if there are two parts, like head is different, neck is different, this one is bipolar hip prosthesis, right? Austin Moore. So Austin Moore is single body with two holes. Thompson is single body with no holes, and bipolar is double body. Head is separate. If you see closely, head is separate, neck is separate. So this one is head, this one is neck. Both of them, they fit with each other. Okay, G? So the three prostheses used for hemiarthroplasty, you must remember hemiarthroplasty and total hip replacement both. Okay. Now, this one is halo traction brace. Traction brace. So this is just as an image base, and if you see here like this, if it fits on the chin, this is a 𝗧𝗵𝗶𝗀 brace. Again, only thing important is the image. If it fits on the chin, 𝗧𝗵 brace. If it fits on the head, hollow traction brace. Hollow traction brace. Now, this one is Taylor brace. Taylor brace. Taylor brace. So Taylor brace is used in tuberculosis. This is used for stabilization of the spine. Used for stabilization of the spine. Now this one is aeroplane splint, used for brachial plexus injury. Brachial plexus injury. Right? Von Rosen splint. It was previously used. So Von Rosen splint is not used now. Nowadays, what do we use? We use Pavlik harness. Now we use Pavlik harness. Okay, Von Rosen splint. Now, this one is for stabilization of cervical spine, and this one is Philadelphia collar. Philadelphia collar. Any one of you, please tell me, what is contraindication of cervical collar? What is contraindication of cervical collar? Where you should not be using cervical collar? What is contraindication of cervical collar? That's my question. So contraindication of cervical collar is penetrating neck injury. Somebody stabs your patient in the neck. In that case, you must not use cervical collar. Okay. So this image is that of Philadelphia collar. Philadelphia collar. Right. Again, the image based questions there. So this is short leg cast. This is cylinder cast. This is used for patella fracture. This one is used for fracture around ankle. This is long leg cast. Fine. Now again, it is used for tibia fracture. This one is important. This is patellar tendon bearing cast. Patellar tendon bearing cast. This is not to be used for patella fracture. This is not used for patella fracture. Again, this is used for tibia fracture. Very good. Okay. You know, Dr. Anirudh Ji, Dr. 𝗧𝗵𝗶𝘀 Ji, the only thing is because, the name is patellar tendon bearing cast. So some students can mistake it that maybe it is used for patella fracture. No, it is used for tibia fractures. Right? Now, what is that? This one is Dennis Brown splint. Dennis Brown splint. Dennis Brown splint used for club foot. Okay, club foot. How will you identify that there is a crossbar? There is a crossbar. Fine. This crossbar. Dennis Brown splint. Right, G? Okay. Now we have to study some of the spine topics, but because we have already seen that once, let us quickly shift to the conceptual part. Okay. Now, you see, your patient may have a number of deformities. If the deformity affects the elbow joint, name of deformity is cubitus. At hip joint, coxa. Knee joint, genu. Hand joint, manus. Okay. Toes, hallux. If the deformity affects the foot, it is pes or talus. Okay. Now, if you see, sorry, please wait. Yeah, here. So if you see the first image, you see the first image is showing you genu varum. Second image is showing you genu valgum. So the word genu, that means there is some problem with the knee joint. So let's say buddies here, this is the knee joint. After the knee joint, we have to look at the orientation of rest of the limb. Orientation of rest of the limb. if the rest of the limb is going towards midline, it is called 𝗵𝗵𝗶𝗀 deformity. If after knee joint, rest of the limb is going outwards, it is called as 𝗵𝗵𝗀 deformity. 𝗵𝗵𝗀 deformity. So if the rest of the limb is going inwards, this is called as 𝗵𝗵𝗀 deformity. If it is going outwards, this is called as 𝗵𝗵𝗀 deformity. Right? Now, see here. How do we know that which joint is abnormal? Suppose we want to have a look at the hip joint. What will we do? So in the hip joint, first what we will do is we will draw two lines like this. First line here through the neck of femur. Second line through the shaft of femur. And then we will measure angle between the two. This angle is called neck shaft angle. Okay, neck shaft angle, normal value is between 120 to 135 degree. Now see here. First is showing you normal hip. Right? But then the feet are going towards the midline. So if the hip joint is normal, that means it is the knee joint which is abnormal. So that is why the name 𝗬𝗎. And because the feet are going towards midline, name is 𝗬𝗎. Again, in the second image, hip joint is again normal. But this time the feet are going away from midline. So again, knee joint is abnormal, 𝗬𝗎. Okay. Now here you see, hip joint is abnormal. Why it is abnormal? Because again we did the same thing. Draw a line through the neck. Draw a line through the shaft. And then we measure angle between the two. So this angle is less than 120 degree. And you see the feet are going towards the midline. So hip joint must be abnormal. So this is 𝗧𝗵𝗶𝗀. If this angle is more than 135, this is 𝗧𝗵𝗫𝗀. 𝗧𝗵𝗫𝗀. Now here, look at the first image and second and third. Let me zoom up. So buddies, what we will do is, we will draw two lines, A and B. So A is through the mid of arm, and then we extend it. And B is through the mid of forearm. Then we measure angle between the two. This angle is called carrying angle. Carrying angle. So carrying angle is the angle between arm and forearm. In normal people, it is 5 to 10 degrees in males and 10 to 15 degree in females. Now look at the third image. So again the same thing. I draw a line through the arm. Extend it to the opposite side. Second thing, I draw a line through the forearm. Then I measure angle between the two. This angle must be more than 15 degrees. So your patient is suffering from cubitus valgus deformity. Cubitus valgus deformity. Cubitus valgus deformity. Look at the first image. I draw a line through the arm. Then I draw a line through the forearm. So the angle between them is minimal. So this is 𝗵𝗵𝗃𝗃 deformity. 𝗵𝗵𝗃𝗃 deformity. For example, gun stock deformity. For example, gun stock deformity. Right? If the wrist joint is abnormal, name of the deformity is manus. Fine. Now, what you see in this image, hand are turned inwards. So this is a varus deformity, manus varus deformity. This is seen in club hand, and club hand indeed is seen in TAR syndrome. So this is an important question for NEET PG, right? If the feet are turned inwards, this is 𝗃𝗃𝗃 varus. If they are turned outward, 𝗃𝗃𝗃 valgus. Same deformity affecting the great toe is called hallux. If the feet are going outward, see here, the great toe, they are going outward. So this is a valgus deformity. If the great toe are going inward, this is a varus deformity. So hallux valgus has got a name, and this is called as bunion. Hallux valgus has a name, this is called as bunion. So image of this question is very important. Hallux valgus, great toe going outward. Now, if the patient has valgus deformity in one limb and varus deformity in the other, buddies, it is called as wind sweep deformity. So they ask you, what is the most common cause? Most common cause of wind sweep deformity is rickets. Most common cause of wind sweep deformity is rickets. And in adults, most common cause is rheumatoid arthritis. Right? Now, whatever you see in the the blue color, these bones, blue colored bones here, they are called as axial skeleton. Axial skeleton. What are the common diseases? Tuberculosis, tumors, ankylosing spondylitis. The other bones, pink colored ones which you see over here, they are called as appendicular skeleton. What is the common disease here? Osteomyelitis, right? And rheumatoid arthritis also. Okay. Now, what important? Yes. So 65% of the bone is made up by hydroxyapatite. Important question. What is the formula of hydroxyapatite? More important question. This is the formula of hydroxyapatite. 10 molecules of calcium, 6 molecules of phosphate, and 2 molecules of hydroxyl. Right? That is the formula of hydroxyapatite. Okay. Then the parts of long bone. So end of the long bone, that is called epiphysis. Epiphysis. Common disease, osteoclastoma. Favorite tumor of examiner. Central part is diaphysis. In between them is metaphysis. Right? Now, what arises from metaphysis? This is very, very, very important question. Let's say, even if you are sleeping and I give you a call and I ask you this question, you should be able to answer. Right? So from metaphysis, osteochondroma, PYQ, osteosarcoma, PYQ, osteomyelitis, PYQ, right? So these diseases, they arise from metaphysis, right G? From diaphysis, what arises? Ewing sarcoma and fibrous dysplasia, okay? Now, not important. Yes. Now periosteum has got two layers, outer layer fibrous, inner layer cellular. Now this layer has got stem cells which can turn themselves, which can convert themselves into any type. Osteoblast form bone, chondroblast form cartilage, fibroblast form collagen. Now, yes, so this anatomy teacher must have taught you this, that periosteum is not present over sesamoid bones. Now, one sesamoid bone is called rider bone, middle part of thigh it develops, right? Now, outer dense part of the bone is called cortical bone. Now this has very little space, no space even for blood vessels. So vascularity is very, very poor. Central part, inner part is cancellous. Fine. So this is very vascular. Okay. Now, for the fracture healing of cortical bones, you know, when you people start studying orthopedics for the first time, I have a bilingual PDF of around 3-4 pages. So in that I've written the concepts in very concise manner. I'll share that booklet also. So here you see, if there is fracture, now see buddies, the outer cortical part and inner cancellous part, both will heal at different rates. Cancellous part will heal very rapidly. Cortical part will heal very, very slow, because cortical part is dense. More calcium will be required. Now, how do we apply it? At metaphysis, most of the bone is cancellous. So, low bone density. So very little cortical bone is present at metaphysis. That is why, dear doctors, metaphysis fracture will heal very, very rapidly. And malunion is common. Now you see all of these fractures, supracondylar fracture, extracapsular fracture, Colles fracture, Smith fracture, they occur at metaphysis. That is why you see deformities are common. Gunstock deformity, fine. Dinner fork deformity, right? Smith fracture, garden spade deformity. So deformities are very, very common because the fracture unites rapidly. Even if the bone is not properly aligned, it will heal, and this will give rise to malunion. Okay, right. So we move very, very quickly to the next small topic here, clubfoot. Now buddies, clubfoot happens to be most common congenital orthopedic disorder in India. Clubfoot is the most common congenital orthopedic disorder in India, right? Remember, world over, around the world, most common orthopedic disorder is DDH, developmental dysplasia of hip. But that is not seen in India. That is second most common in India. So in India, most common congenital orthopedic disorder is clubfoot. Fine. Now clubfoot, most common cause idiopathic, most common association neural tube defect. myelomeningocele. It is seen in firstborn males and more commonly it is bilateral, whereas DDH, it is seen in firstborn females and it is unilateral. DDH is developmental dysplasia of hip. Okay. Okay. Now, so chief pathology is small talus, right? What are the deformities? Mnemonic is cave. So your patient will have cavus, increased vertical arc of foot, increased vertical arc of foot. Adductus. If me and you stand, our fingers will be facing forward. But if the patient of club foot stand, it will be like this, that fingers will be close to each other. Fingers will be close to each other. That is adductus. And you see the feet is turned inwards. So that is third deformity, varus. The feet is turned inwards. Heel does not touch the ground. Heel does not touch the ground. So this is normal. This is club foot. How to make the diagnosis? Antenatal before birth. We'll do ultrasound at 24 weeks of pregnancy. At the time of birth, when the child is born, suppose this is the foot, right? Pediatrician will mark a point A. This is leg. So pediatrician will twist it so hard that the feet will be able to touch the leg like this, right? But in club foot, pediatrician is not able to do this. Why? Because you see, let's say the pediatrician, he marks A over here and B over here. Now when he is trying to do this movement, these tendons, tibialis posterior and Achilles tendon, they will not allow the foot to move. Okay. Now, treatment. Earlier we use kite method. You don't need to remember. Now what do we use? Now we use Ponseti method. This is done by doctors and we have Pirani score to see whether it is working or not. Okay. Now what we do here? We do serial casting, one after the other. So this is how the child comes to you with club foot. So you will apply the first cast. It will correct cavus. Then after few weeks you will apply the second cast. This will correct adductus and varus together. And this one will correct equinus. Okay. So correct order. This question has been asked many a time. What is the correct order? Cavus, adductus and varus together and then equinus. Okay. Equinus is least correctable deformity. Okay. Now, even after you have corrected it, you will have to use Dennis Brown splint. Again, buddies, you just have to remember the image. Okay. You might have to use this for 7 years. If the child comes to you at 1 to 4 years of age, now you'll have to use surgical method, posteromedial soft tissue release. If it comes at 4 to 8 years of age, you'll have to do osteotomy. Now for NEET PG, you need to remember the names. Ivan Delvin and Litblau. 8 to 10 years, wedge tarsectomy. A part of the foot you will have to cut. At 10 years, you will have to do triple orthodesis. Which three joints? TN, TC, CC. Talo-navicular, talo-calcaneal and calcaneo-cuboid. Fine. Now, if the correct order is not followed, your patient will develop rocker bottom foot. Rocker bottom foot. R for rocker, R for round. So rocker bottom foot is round from below. Rocker bottom foot is round from below. If the correct order is not followed, your patient will develop rocker bottom foot deformity. The word orthodesis means fusion. Okay, club foot. Right, buddies? So important topics. We start with the next one. Rheumatoid arthritis. Rheumatoid arthritis, autoimmune disease. It is associated with HLA, DR1 and DRW4. Associated with Epstein-Barr virus also. This is a disease of middle-aged females. It is an autoimmune disease. Anirudh Ji, this is a rapid revision one, buddy. Question you ask me. If you ask me a question, I'll be able to answer. So what happens is, IgM antibodies that develop against IgG immunoglobulin. So what forms? Immune complexes. Immune complexes means antigen plus antibody. So their first target is the synovium. Their first target is the synovium. So initially they will attack on synovium. Synovium will be converted to pannus. Synovium. Inflamed synovium is called pannus. Most common pattern. How are the joints affected? Symmetrical polyarthritis. Suppose I am your patient. Right side wrist involved, left side is also involved. Right side finger involved, left side is also involved. Right? Most common joint, metacarpophalangeal joint. Right? Remember, metacarpophalangeal joint is spared in osteoarthritis. Then PIP joint, proximal interphalangeal joint, and wrist joint. Less common, hip joint. Remember, hip joint is most common joint which is involved in osteoarthritis. Right? Rarely involved are cervical spine, that is atlantoaxial joint. Now, other organs are also affected like lungs. Your patient will have interstitial fibrosis. Eyes, your patient will develop dry eyes. Pleural effusion will be there, myocarditis will be there. Your patient will develop rheumatic nodules. So, rheumatic nodules that develop on the extensor surface. And most common site, dear doctors, is olecranon. Most common site is olecranon. Now, when the condition of patient improves, the nodules disappears. When the condition of patient worsens, the The nodules, they reappear again, right? Dr. Cordon, see buddy, it is the lovely students like you who make us. We are we because of you people. So whatever is there on your screen, that is for you only. Fine, I'll share the PDF, don't worry about it. Now, rheumatoid arthritis, your patient will develop multiple deformities. For example, here what you see, if there is just flexion at the DIP joint, your patient will develop mallet finger. If there is flexion at PIP and hyperextension at DIP, your patient will develop boutonniere deformity. If reverse is there, that there is flexion at DIP and hyperextension at PIP, your patient will develop swan neck deformity. Make no mistake, DIP joint is not inflamed. DIP joint is not inflamed. Tendons around the joint are inflamed. Tendon around the joint are inflamed. This is a very, very important concept. They ask you which joint is spared in rheumatoid arthritis. DIP joint is totally spared in rheumatoid arthritis. Right, buddies? Flexion deformity of the foot. Flexion deformity of the foot. This. So this is called as hammer toe. If your patient thumb is like that, always extended, no flexion, this is called as hitchhiker thumb or Z deformity, as if someone is asking for a lift. So anyone who's asking for a lift is called a hitchhiker. Dr. Anirudh G, mallet finger, if it is because of trauma, treatment is surgical. Mallet finger, if it is because of rheumatoid arthritis, treatment is conservative. Coming back to rheumatoid arthritis, your patient, you see all the ligaments between radius and ulna, they will break. You will be able to move radius away from ulna. This is called as piano key sign. Piano key sign. Investigation, RA factor levels are high. What is RA factor? RA factor is IgM antibody against FC portion of IgG. This is very, very important. Now, when the disease is waxing, that means patient condition worsening, RA factor levels would be high. When the disease is waning, that means patient condition improving, RA factor levels would be low. What is the problem with RA factor? Problem is that it is non-specific. It is raised in other conditions also. Okay. Then, what is the specific investigation? Specific investigation is anti-CCP. Now, this is also known as ACPA. ACPA, anti-citrullinated peptide antibodies. ACPA, anti-CCP. Right? X-ray. First sign which you see is juxta-articular osteopenia. Juxta-articular osteopenia. Treatment, DMARDs. Drug of choice is methotrexate. Osteoarthritis, they ask you what is the most common age more than 65 years. It is common in men who are obese. Okay. Secondary osteoarthritis, it occurs when the joint is destroyed by disease, right? Not by aging. Not important. Primary osteoarthritis, joint is destroyed by age. Most common joint is knee joint in India and hip joint overall. Now this is because of Indian style of toilet and our habit of sitting on the ground. Okay. Now clinical feature. What happens is that you see this image. The blue colored thing which I have shown is the cartilage. Yes, Ragnar-ji, definitely enough. Definitely enough. Now the blue colored thing which I have shown you here, it is the cartilage. Now, cartilage on the medial side is destroyed very early. Lateral side is preserved. So lateral side of the bone will stay away from each other, whereas the medial side of the bone will come close. So lateral side of the bones, they will stay away from each other. Medial side will come close. So that is why your patient develops 𝗵𝗵𝗶𝗃 deformity. 𝗵𝗵𝗃 deformity. Right? 𝗵𝗵𝗃 deformity is very common. Now, metacarpophalangeal joint, as I told you, it is spared. It is not inflamed. PIP joint is swollen and it is called as Bouchard node. DIP joint is swollen, it is called as Heberden node. On X-ray, what do you get to see? Asymmetrical loss of joint space. So if you see here, buddies, here space is still there, but here, as you can see, there is no space. So here the space is gone, whereas on the lateral side the space is still there. Fine. Asymmetrical loss of joint space, that means there is more loss on the medial side. Now, what is that? Eburnation. Eburnation is bone destruction due to bone rubbing against bone. So osteophytes form. So osteophytes are bone edges. Now, arthroscopy is confirmatory. Word artho means joint, scopy means camera. So we take camera inside the joint and we confirm the diagnosis, plus we remove any loose bodies. Now, osteoarthritis is the most common cause of loose bodies in the joints in elderly. Gold standard treatment is total joint replacement. Total joint replacement. Gold standard treatment. Right? Psoriatic arthritis. It occurs in 2 to 10% of psoriasis patients. It is associated with HLA-B27. Don't make this mistake. Ankylosing spondylitis is associated, but psoriatic arthritis is also associated. Right? Now, most common age 30 to 50 years and male-female incidence is equal, not important. Now, most common pattern is asymmetrical arthritis. If I am your patient, right hand involved, left may be normal. Okay. Now here, fingers are swollen. They are called as sausage fingers. Right. Now, bone destruction will occur, and on X-ray, we will get to see typical pencil in the cup deformity. Pencil in the cup deformity. right? So this is your patient of PA. PA means psoriatic arthritis. Pencil in the cup deformity. Now, skin will develop fold, and these folds are called opera glass hands. Opera glass hands. Now, this is important only for NEET PG. So the fingers, they become small, but if you pull, they become long. This is called as telescoping. This is called as telescoping, right? Ankylosing spondylitis, much of it we have already studied. Fine. Important one I will highlight. So ankylosing spondylitis is associated with HLA-B27. So it starts at sacroiliac joint. Primary site of inflammation is enthesis. Remember, in rheumatoid arthritis, primary site was synovium. Here, primary site is enthesis, right? So clinical feature is your patient will develop backache. X-ray will show squaring of vertebra. Image is important, right? Then bamboo spine, again this image is also important. Then dagger sign, railroad sign, trolley track sign we have already studied. Now for NEET PG you have to read the names of these tests. So if we have to check whether the sacroiliac joint is working normally or not, we will be doing Ganseland test. This is important only for NEET PG, right? Other test is Faber test, Patrick test, figure of 4 test, right? Now for lumbar spine, name of the test is Skober test. Now this disease has many extra articular, that means not related to the joint. So most common is iridocyclitis. Your patient can have IgA nephropathy or inflammatory bowel disease. Inflammatory bowel disease, right? Okay. So now very important topic here, tumors. I'm not stopping because I have little time and I want to deliver the maximum. So if you have any queries, don't hesitate, just bring them on. Okay. Now you see, majority of the tumors of bone, majority, I'm repeating, majority of the tumor of the bone, they are not own tumor, they have come from some other organ, right? Primary tumor, that means arising from the organ itself. Secondary tumor, coming from some other organ. So secondary tumor of the bone, that means tumor coming from some other organ, are over 100 times common. Primary tumor of the bone are very, very rare. So if they ask you this question, what is the most common bone tumor? Secondary cancer from other organ. In males, commonly they come from prostate. In female, they come from breast. And if they ask you most common overall, they will come from prostate. Okay. Now, some of the cancers, if they reach bone, they will help in bone formation. So here the mnemonic is PCM, cancer of prostate, carcinoid and medullary carcinoma. And some of them, they will destroy the bone, that is osteolytic. like renal cell carcinoma and follicular carcinoma. In surgery, you must have read that follicular carcinoma, it gives rise to pulsatile secondaries, very vascular secondaries. What you get to see is only blood vessels. You don't get to see anything else, only blood vessels. So vascular are secondaries. Now, most common site of secondary tumor is dorsolumbar spine at posterior aspect. In the spine and posteriorly. Right? Now, there is a mnemonic: BBC goes everywhere. Carcinoma of the bronchus, urinary bladder and colon, it can go to any bone, even small bones. Okay. Now one liners. डॉक्टर मोहित जी हैं हमारे साथ अभी. डॉक्टर मोहित जी को वन लाइनर का बड़ा मन था पढ़ने का. So what is the most common primary malignant bone tumor? That means it arises from bone tissue only. So here the answer is multiple myeloma. It arises from bone marrow. What is the most common primary malignant bone tumor of non-hematopoietic origin? Non-hematopoietic origin means from the hard bone. So here the answer is osteosarcoma. Second most common chondrosarcoma. Third most common is Ewing sarcoma. Right? Now, we shall now study 5 or 6 benign tumors and then malignant tumors. Okay? Now see. First is osteochondroma. It is most common benign bone tumor. Now it is not a true tumor because it will stop growing after skeletal maturity. Growth stops at maturity. Now it is an exophytic lesion. Exophytic means coming out. And where do we see it? We see this at metaphysis. We see this at metaphysis. Right? Okay. Now, treatment is excision if it is symptomatic. What it might happen is that it may press a bursa or a nerve. Then it will cause pain. Now, next is enchondroma. It is the most common benign tumor of hand bones and it affects the phalanges. Now, for NEET PG, you need to remember the syndromes which are associated. So, enchondromas are associated, as you can see written on the top, Maffucci syndrome and Ollier disease. Ollier disease. Right? Nothing more is important. Osteoma is just bone overgrowth, nothing else. Now, it might look bad, it might look ugly, or it might block a sinus. Okay. Now, next is osteoid osteoma. Very, very important. It is most common benign true bone tumor. Now, Robin says that it is seen in teenage and early 20s. Right? So that means it is seen in young people. Right? Commonly seen in males and it is seen at femur or tibia diaphysis. This one is an important point which you should always remember. Diaphysis. Right? Clinical feature, bone pain which is very mild. So mild is the pain that it is absolutely relieved by aspirin only. Otherwise, tumor pains are very severe, but here the pain is very, very mild. It is just relieved by salicylates, right? And this image, even if you are sleeping, even if you are partying very, very hard, right? Let's say you are in some party and you feel like enjoying only. You don't want to look at anything else. Even then, when I show you this image, you must be able to answer. So, at the diaphysis, if you see black center, white periphery, close your eyes and take osteoid osteoma. That is the only answer. Okay. So this is a very, very important image. Osteoid osteoma. Right, buddies? Treatment is radiofrequency ablation. We'll have to burn this up because this is actually a true tumor. This is actually a true tumor. Right? Okay. Now, osteoblastoma is an immature version of this tumor. Is an immature version of this tumor. Just give me a minute. I don't know what is happening here. But I need to close it once and I'll open it again. Yeah, now it's okay. Right. So osteoblastoma is an immature version. This is how you compare both of them. Right. So osteoblastoma, as you can see, will be more than 2 centimeter and osteoid osteoma less than 2 centimeter. But here is the differentiating site. Osteoblastoma is generally seen at spine. And it is aggressive one. Otherwise, nothing is important. Osteoclastoma, giant cell tumor. Now, there are 5 E's about it. First, it is located at epiphysis. It is located at epiphysis. Right, buddies? See, this is diaphysis, this is metaphysis, this is epiphysis. So this tumor is located at epiphysis, but it is not located in the center. It will be located at one of the sides. That is why eccentric. Expansile, it is rapidly expanding. It will make the bone very, very thin like eggshell. En bloc excision, that means complete removal is the treatment. Complete removal is the treatment. Mohit ji, you are from Rajasthan. I once had been to Rajasthan. So उन्होंने मुझे वो कचौरी खिलाई और उसके बीच में घी डाला. मैंने उनसे पूछा कितना घी डालोगे? बोले बस इसको पीते जाओ पीते जाओ. तो ये मत पूछो कितना टाइम बचा, बस पढ़ते जाओ. I'll end, don't worry. थक गए भाई. मैं बदला नहीं ले रहा हूं. So you see, it is not present at one of the side. It is not present in center, but it is present at one of the sides. Right? Now the image is very, very important. Why it is called giant cell tumor? Because on biopsy, giant cell with 40-50 nucleus are seen. Simple bone cyst. Only thing which is important is this image. X-ray showing trapdoor sign, which is also called as fallen leaf sign. Also called as fallen leaf sign. So there is a bone fragment inside. Right? Okay. Aneurysmal bone cyst. Again, in the aneurysmal bone cyst, what is important is this image. You should be able to identify multiple septa. Multiple septa. Many of the students, they ask me, sir, how to differentiate it from Ewing sarcoma, right? Now, Ewing sarcoma, common age is 5 to 15. Here, common age is 20 to 30. Okay. Okay. So now we shall see in another 5 minutes the malignant tumors. Okay. Now, osteosarcoma is the first one. It is most common primary malignant bone tumor of non-hematopoietic origin. Non-hematopoietic origin means hard bone and not from bone marrow. Right? Then it is the most common malignant bone tumor in children. Most common radiation induced bone tumor. That is why the tumor is radio resistant. Most common site is metaphysis of distal femur. Right? Now it is of two types. Primary osteosarcoma, which occurs in young. Secondary osteosarcoma will occur in Paget disease, fibrous dysplasia. Right? Important. Common gene mutation. You have to remember RB gene mutation and P53 mutation. Right? Important. Remember, please. Sunburst appearance and Codman triangle I have already shown you. Biopsy will show nuclear pleomorphism. Hyperchromatic nuclei. Hyperchromatic nuclei means there is too much DNA. Rapidly dividing tumor. Treatment is first we will do chemotherapy and then we will do surgery. Dr. Bhagath, is it scheduled for today, pharmacology? Why chemotherapy is given first? Because most of the tumor are metastatic. Right? Ewing sarcoma. Ewing sarcoma has got round cells. Most common age 5 to 15 years. Most common site in long bones is femur. Right? In flat bone is pelvis. Anyone, is the live class pharmacology scheduled for today? I wasn't aware. Somebody just mentioned it. Can anyone please tell me when is the pharmacology class scheduled? Today, tomorrow, what day? So clinical features are pain, fever, swelling. So they are similar to osteomyelitis, but osteomyelitis will occur at metaphysis, whereas Ewing sarcoma will occur at diaphysis. Onion peel reaction I have already told you. Biopsy will show pseudo-roseates, cells sitting in circles. If you do the gene mutation and karyotyping, what you will see? Translocation. T7 and 22 and 11 and 22. If you do the immunohistochemistry, you will see tumor is positive for CD99, CD57 and S100. Tumor is radiosensitive. Even then the treatment is surgery. Why? Because most of the patient are small children. So you will not be able to give them radiotherapy. Multiple myeloma, very aggressive disease from red bone marrow. Males, it is seen in males 50 to 70 years of age. Now, your patient will have fatigue, weight loss, right? Now, X-ray will show punched out lesion called as raindrop skull. I will tell the difference between raindrop skull and salt and pepper skull. Now, what happens here in multiple myeloma, that cancer cells, they destroy the bone. When they destroy the bone, calcium is released. That means your patient will develop hypercalcemia, right? Treatment is chemotherapy, melphalan, bortezomib. This is what you need to remember, and thalidomide. Now, the difference between salt and pepper skull and raindrop skull. Now, salt is white in color, pepper is black in color. This skull is seen in hyperparathyroidism. Now, what happens in hyperparathyroidism? There are excessively high levels of PTH, parathyroid hormone. Because of that, bone resorption occurs. Too much calcium is removed from the bone. So, bone density decreases. Area appears black like pepper. So, from where the calcium is removed, that area appears black. Now, excess of calcium which enters the blood is deposited everywhere in the body, including bone. So where that excess calcium is deposited, that area will appear white. So in salt and pepper skull, we have white areas, black areas. Whereas in multiple myeloma, only black areas are seen. Only black areas are seen. That is the difference between multiple myeloma and salt and pepper skull. Right? Important. Okay. Now, very quickly about the hip joint. It is a very stable joint. Hip joint is extremely stable joint. We know it. Right? Now, hip joint, if the angle is less than 120, we say that our patient has 𝗧𝗵𝗶𝗀𝗃. Fine. If it is more than 135, we say our patient has 𝗧𝗵𝗶𝗀𝗃. Now, developmental dysplasia of hip is most common orthopedic disorder around the world, but it is second most common in India, because in India, mothers, they hold the baby like this. So legs are spread wide apart. So in this position, the DDH usually does not occur. Even if the child is born with DDH, some of it will be automatically corrected. Right? Now there are 4 F's about DDH. Family history. It is common in firstborn. It is common in the foot first delivery. Especially frank breech. Frank breech means knees are extended. Knees are extended. Right? It is common in females. Right? See, this baby will not be able to open her legs. This baby will be able to. Right? Now, most of the cases are unilateral. Most of the cases are unilateral. Okay. Now, the clinical feature. There will be apparent shortening and feet, they will not touch the ground. So child will compensate by walking like this, toe walking. Okay. Now, 2 tests we perform. Barlow test. We try to do the dislocation. Dislocation is very easy. Second test is Otolani. Relocation is also very easy. Let me show you images. So child comes, femur head is inside the acetabulum. Just apply minimal force and it will come out. This is Barlow test. Child comes, femur head is out of acetabulum. Just apply minimal force and it will go inside. Right? So Barlow test and Otolani test. Right? Next is Galeazzi test. Make the child lie down on table with knees flexed. Normal side will appear high. DDH side will appear low. Galeazzi test. For bilateral DDH, only name is important. 𝗡𝗵𝗃 test. 𝗡𝗵𝗃 test. What is the investigation? 0 to 6 months of age, you will perform ultrasound. More than 6 months, investigation of choice is MRI. X-ray will show broken Shenton arc. Shenton arc is broken in neck of femur fracture also. It is broken in dislocation also. What is broken Shenton arc? So you see, this is normal Shenton arc. If you draw a line on the medial border of femur, draw a line on the inferior border of pubis, what you will notice is that these two lines, they will meet. But if there is DDH, these lines will not meet and there will be a gap. There will be a gap. So that is broken Shenton arc. Treatment. So this image is very, very important. Pavlik harness. If the child comes to you at 6 to 18 months of age, now you will have to do surgery. 18 to 36 months of age, you will have to do osteotomy. 3 to 6 years of age, you will have to do acetabular augmentation. All of them are important only for NEET PG. That too, if they want to ask you a difficult question. Otherwise, such kind of question also don't come in NEET PG. 6 to 10 years of age, there is very high risk of avascular necrosis, right? And more than, so that is why we don't do any surgery. 6 to 10 years of age, we don't do any surgery because there is very high risk of avascular necrosis, which is called as 𝗵𝗲𝗃 disease. More than 10 years, the treatment is total hip replacement. Total hip replacement, right? So next is 𝗵𝗵𝗃 disease. So 3 doctors who worked on it, 𝗵𝗵𝗃, right? So what it is? Spontaneous, that means automatic avascular necrosis of femur head. Avascular necrosis of femur head. Now what is cause? Idiopathic. Deficiency of protein C and S. These are natural anticoagulants. Because of that, thrombus will form in the vein of the head of femur. So that is why blood supply will be blocked. Artery will keep on bringing blood, but this blood cannot go out because the vein is blocked. So watch this carefully, what happens. Vein is blocked. Artery keeps on bringing fresh blood. Artery keeps on bringing fresh blood. Now, head of the femur will become full of blood, but this blood cannot go out. What will happen after a while? It will lose all the oxygen and the femur head will die. Okay. Clinical feature, painless limp. Then your patient will have pain. Investigation of choice will be MRI. X-ray will show crescent sign. Crescent. Like this. Crescent sign. Dead bone will appear like crescent, half moon. Then body start destroying the bone. Body starts eating away the dead bone. So this is what we get to see. This is called as bite sign. Compare this with the normal side. You see here, it's all broken. So body will send macrophages to eat the dead bone. Now macrophages, they will start eating the bone at one side like this. So this is called as gauge sign. Image is very, very important. Most of the cases they resolve spontaneously. Nothing is required. But if the surgery need to be done, that is muscle pedicle graft or Chiari osteotomy. Chiari osteotomy. If you don't want to remember too much, just remember your age. Just remember age of the patient. 6 to 10 years is the common age. Just remember the bite sign. This is important one. Just remember the bite sign. That is the minimum you must be remembering. Fine, super important. Next topic is slipped capital femoral epiphysis. Most common disorder around the hip in adolescent. It is associated with obesity, and obesity is associated with hypothyroidism. Now, the cause is not important. Only thing is what will happen, that epiphysis will slip away from the physis. That is why the name slipped capital femoral epiphysis. Now, what is important? The clinical feature, that is Dramon sign. Dramon sign. You ask the patient to do flexion. You just ask the patient to do flexion, and there will occur external rotation along with the flexion. External rotation along with flexion. Dramon sign. This is very, very important for NEET PG. Investigation of choice, MRI. Fine. X-ray will show Trethovan sign. What is Trethovan sign? You draw a line on the neck of femur and then you extend it on both sides. You will see that if everything is normal, line will pass through the head. But if there is slipped capital femoral epiphysis, line will not pass through the head. The line which you did draw at neck, जो line आपने neck पे draw करी, आप देखोगे कि head के बीच में से नहीं पास होगी. Trethovan sign. Treatment is close reduction and pinning. Close reduction and pinning. Now, the next topic is dislocation. Hip joint dislocation. Right? So, most common type is posterior. Right? So, posterior like this. And posterior hip dislocation, it is common in car dashboard injuries, right? Clinical features are fadder, flexion, adduction and internal rotation. You are not able to palpate femoral artery, that is called as vascular sign of Narath, right? Treatment is closed reduction. Anterior dislocation, this is common in bike injuries, common in motorcycle or motorbike injuries. Clinical features are Faber, flexion, abduction and external rotation, right? So complication are injury to femoral artery, vein, nerve. Central dislocation is common in osteomalacia. Neck of femur fracture. So in the neck of femur fractures, we have to study two fractures. First is extracapsular, also called as intertrochanteric, right? Now what we do here is, very quickly we will compare. So this one is extracapsular, this one is intracapsular. We'll compare both of them. Extracapsular common around 70 to 80 year, intracapsular common around 50 to 60 years of age. Fine. Now extracapsular common complication is malunion. Here common complication is non-union. Fine. Now extra information which you might need here. What is the treatment? Treatment is dynamic hip screw or intramedullary nail. Now treatment of intracapsular fracture is important for NEET PG students. Please allow me 1 or 2 minutes. So first we will divide our patient into young and old, right? First let's see what do we do with young. Fine. Here we will do closed reduction with internal fixation. Now old, if they have osteoarthritis, the treatment is total hip replacement. If they have no osteoarthritis, treatment is hemiarthroplasty, right? This much is is the easy one. Now old, it might be divided into two groups: recent fracture, old fracture. So if it is a recent fracture, you will do these surgeries. If it is an old fracture, there are chances your patient might have avascular necrosis. Then the treatment is 𝗵𝗵𝗆 operation. If there is no avascular necrosis, then Powell osteotomy. Just give me a minute. Not 𝗵𝗵𝗀𝗃, I'm sorry. So here you will do muscle pedicle flap. Now this is known as Mayer operation. Very quickly, kindly allow me to repeat. How do you treat neck of femur fracture? First, if your patient is young, so you will divide your patient into two groups, young and old. In young patient, you will do closed reduction, internal fixation. In old patients, you will further divide them into two, recent fracture, old fracture. Old means more than 3 weeks old. If they have osteoarthritis, total hip replacement. If no osteoarthritis, hemiarthroplasty. If it's an old fracture, they might have avascular necrosis. Then the treatment is Mayer operation. If there is no avascular necrosis, treatment is Powell osteotomy or 𝗵𝗵𝗃𝗃 osteotomy. Right? Now here, what else you need to remember? Just one more minute. Yeah, you need to remember Powell classification. It is based on angle of fracture line with the horizontal. So this is horizontal line, this is fracture line. And Garden classification, it is based on degree of displacement. Only the basis you need to remember, nothing else. Right? Now, femur fracture. Femur fracture. This is a PYQ which has been asked in the last 2 or 3 exams maybe. So the distal fragment, if there is a femur fracture, distal fragment, it will hit the popliteal artery. It will hit the popliteal artery. Right? Distal fragment, it will hit the popliteal artery. Right? Very, very important. Treatment, less than 6 months Pavlik harness. Again, what is important? Image. 6 months to 2 year gallo traction. How will you identify gallo traction? Hips will not be touching the bed. 2 to 5 year hip spica cast. Again, what is important? Image. 5 to 10 year elastic bendable nails. More than 10 years intramedullary nail. Transient synovitis of hip. Only thing which you need to remember is that it is the most common cause of limping child. It is the most common cause of limping child. Rickets, I leave to pediatrics revision, right? This one will do. This one will do. See, buddies, we started the class at around 10. Yeah. So let's continue for another 10 minutes, please. I know that you guys are tired, but another 10-15 minutes, please. Even my laptop seems to be tired. Right? So you see here, what we are reading is rickets have left for pediatrics teacher. Osteomalacia, it's also called as adult onset ricket. It is common in women of developing countries, because you see, women, they remain covered all the time, so they cannot make their own vitamin D. Now, X-ray here will show insufficiency fracture, which is also known as milkman fracture, also known as pseudo fracture. Now, they are thought to be impression of pulsating blood vessel on the bone like this. Continuous pressure may cause these fractures, right? Now, most commonly they are seen around neck of femur. Okay, X-ray will show triradiate pelvis. ठीक है जी, will show tri-radiate pelvis. Tri-radiate pelvis, right? But definitive diagnosis is by bone biopsy. Okay. Now, treatment is to give vitamin D injection and calcium. Now, prophylactic, that means preventive action is to be done when your patient is taking anti-epileptic drugs, phosphate binding antacids, and glucocorticoids. So these drugs, they interfere with vitamin D metabolism. Okay. Now, but the next disorder is osteoporosis, right? What happens in osteomalacia? There is good volume but low bone density. What happens in osteoporosis? There is low volume as well as low bone density. There are two types of osteoporosis: primary osteoporosis and secondary osteoporosis. Primary osteoporosis, that means there is no other disease which is causing osteoporosis. Now it is of further two types. Type 1 is post-menopausal. Any female who is menstruating today will develop menopause, and after menopause she will develop osteoporosis, right? Second is senile. Anyone who is young today one day will become old. He will develop osteoporosis. That is why it is most common type of osteoporosis. Now, secondary osteoporosis, that means some other disease is causing. Most common cause is steroid intake. Then it is seen in tuberculosis. Then it is seen in rheumatoid arthritis, right? Now, clinical feature Dowagger hump. Patient will be bending forward. Then patient might develop fracture. Right? Most common site of these fractures is dorsolumbar spine. Right? Now, X-ray will show fish mouth vertebra like this. Fish mouth vertebra. But these changes are seen when 30 to 40% of the bone density is lost. Right? So that is why the gold standard investigation is DEXA scan. Dual energy X-ray absorptiometry. Now here, what do we get to see? T-score. This is very, very important. T-score. So T-score is when bone mineral density of the patient is compared with the younger individual. Race and gender of the young individual should be same as patient. For example, if you are doing T-scan, T-score on me, so my bone mineral density you should compare with younger individual who should be a male, who should be an Indian, right? So this is how you perform the T-score. Now, if the T-score is between -2.5 to -4, that means your patient has osteoporosis. Z-score is when bone mineral density of the two patients having same age, gender and race are compared. So it will just tell you which patient is losing bone mass rapidly. Okay. Then the drugs. So there are three groups of drugs. First are the drugs which Drugs which decrease osteoclast activity: bisphosphonate, calcitonin, estrogen, selective estrogen receptor modulator, and denosumab. Second are the drugs which increase osteoblast activity. And what is that? Teriparatide. Teriparatide is the initial drug of choice in severe osteoporosis. Third are the dual action drugs. So they act both on osteoclast as well osteoblast. What is the surgical treatment? Injection of bone cement. What is the formula of bone cement? Polymethyl methacrylate acetate. Osteogenesis imperfecta, right? So it is also known as brittle bone disease. What is the pathology? Defective collagen. How are bones formed? Over collagen, calcium is laid. But in osteogenesis imperfecta, collagen is defective. Calcium is normal, collagen is defective. What is the cause? Genetic mutation, COL1A1. Which collagen is most commonly affected? Type 1. Bones are weak, ligaments are loose, teeth are small, sclera is very, very thin. That is why it appears blue. Why the sclera appears blue? Because the sclera is very, very thin, so thin that the blue colored choroid is easily visible. Now, bones can be easily deformed because they are very, very weak, right? So nerves are very often compressed. So your patient will develop deafness. That is the mnemonic for you to remember the clinical feature BDSM, right? Blue sclera, dental abnormalities, hearing loss, and multiple fracture. Drug of choice, bisphosphonate, surgical treatment, Sofield-Miller osteotomy. Achondroplasia, most common cause of genetic dwarfism, autosomal dominant. Mutation name is important only for NEET PG. Often there is no family history. Clinical feature, small height and normal IQ. All the fingers are of same size. Single prominent line on the hand. Hands are like this. 1, 2, 3. Trident hands. Pelvis is wide but not tall. Pelvis is wide but not tall. That is called champagne glass pelvis. Vertebrae have beaks. Rhizomelic micromelia, that means proximal bone like humerus and femur are small, prominent in proximal bones. Paget disease. You need to remember the genetic defects. First thing, right? Now, to understand Paget disease, it has got three phases. In the first phase, what happens is activity of the osteoclast suddenly becomes very, very high. In the second phase, activity of osteoblast also becomes very, very high. In the third phase, activity of osteoblast is still very high, whereas activity of osteoclast is reduced. So in the first phase, activity of osteoclast is very, very high. That is why bone is destroyed at multiple places. So level of hydroxyproline and deoxypyridinoline will rise. In the long bone, you will get to see blade of grass sign or candle flame sign. In the second stage, there is too much new bone formation and too much bone destruction. Because there is too much bone formation, alkaline phosphatase levels would be high. Because there is too much bone destruction, pyridinoline level, hydroxyproline levels would be high. X-ray will show cotton wool skull, that is increased thickness of skull bone. X-ray will show, X-ray of the spine will show picture frame sign like this, and late stages will show ivory vertebra. Now, late stage will show increase skull size, ever increasing skull size. Skull size बढ़ता ही जाएगा, right? Okay. Then Tam-O-Shanter sign. That is Tam-O-Shanter sign. Your patient will start wearing this hat. Just give me a minute. Just give me a minute, buddy. Okay. Now, what you need to remember is that this disease is seen around 50 years of age. Male-female incidence is equal, right? Cranial nerves are paralyzed. Multiple cranial nerves are paralyzed, and there is a PYQ, which cranial nerve is commonly affected, right? 8th cranial nerve. Image based question. Often there occurs banana fracture, right? What is banana fracture? Let's say this is long excess of bone. So fracture, they occur like this. Fracture, they occur at 90 degree. Like you break this banana at 90 degree. Banana fracture. If you look at the bone, cells are disorganized, called as mosaic bone. Treatment: early stage bisphosphonate to stop osteoclast, late stage osteotomy. Now, osteoporosis, there is defective osteoclastic resorption, right? Okay. Now, there are two inheritance patterns. Autosomal recessive disease is severe. There will be absolutely no space for bone marrows. So, bone marrow, blood formation will occur in liver and spleen, right? X-ray will show widening of the bone. X-ray will show widening of the bone which is called as Erlenmeyer-Flask deformity. Erlenmeyer-Flask deformity. Spine X-ray will show, sandwich vertebra, also called as endobone, bone within bone. Treatment is stem cell transplant. Treatment is stem cell transplant, right? We are left with little time, but just the important ones here. So this is Dupuytren contracture. So if you see fingers permanently bent like this, that is Dupuytren contracture. Dupuytren contracture, right? Now there will be too much fibrosis. Most commonly it affects ring finger and then it will affect the little finger. It is commonly seen in diabetics and cirrhotics. Treatment is excision. You'll just give a cut over here. De-Quervain disease. You have to remember the names of the tendon. Which tendon are affected? Abductor pollicis longus, extensor pollicis brevis tendon. Investigation. Finkelstein test. It is done in two parts. First, doctor will hold the thumb and ask the patient to bend fingers like this. In the second part, doctor will ask the patient to close the thumb and then bend the hand like this, right? Finkelstein test. Earlier, what did the doctor used to do? Doctor used to hold the hand and bend the hand of patient like this. There would be severe pain. इश्कॉफ टेस्ट. आदित्य जी वहां चलता है यूट्यूब अपना चाइना में? Sachin ji, honestly, I'm not very well aware of that. Apart from that lysosomal storage disease है, Fabry disease. But what are the clear orthopedic manifestation? That I'm not sure here. Fabry disease, I haven't studied in orthopedics. It is just a lysosomal storage disease. Probably some alpha-galactosidase enzyme, I'm not sure. Okay. Now trigger finger. In trigger finger there will be a nodule near metacarpophalangeal joint. Nodule near the metacarpophalangeal joint. Nodule near metacarpophalangeal joint. Right? Now, then, so every time your patient opens the finger, click, 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 click sound will be heard. Okay. So treatment is excision. Tennis elbow is tendinitis of common extensor muscles. Over here, pain will be felt. Then, what is the name of test? Cozen test. For NEET PG, you have to remember another test. Aditya ji. Bas another 2-3 minutes, we are going to end the class. So you see Maudsley test. Just ask the patient to raise the finger like this. There will be pain. Treatment is NSAIDs, braces, or injection of platelets that will cause healing. Golfer elbow, tendinitis of medial flexor origin. There are different names of this condition. Javelin thrower elbow is an acute injury. ओके ओके भाई मोहित जी, अभी करा देते हैं। कार्पल टनल सिंड्रोम इज entrapment of median nerve. Now here pain will occur in the distribution of median nerve, right? Median nerve will be compressed, patient will become clumsy, and this is common in women. Okay, Tinel test is positive, you do tapping and symptoms will occur. Fallon test, ask the patient to hold the thumb or hold the hand like this, there will be pain. Opposite, reverse Fallon test, right? Treatment is physiotherapy or cut the flexor retinaculum, cut the flexor retinaculum. ओके, जस्ट गिव मी अ मिनट। हमारे डॉक्टर मोहित साहब ने बोला कि रिकेट्स भी पढ़ना है अभी। अब इतना सख्त उनका आदेश कैसे मना करें। नाउ rickets in India, it occurs due to dietary deficiency of vitamin D and calcium. Dietary deficiency of vitamin D and calcium. Our body can make our own vitamin D by ultraviolet rays. Which ultraviolet rays? Ultraviolet B rays. They can help make vitamin D, but excess of these rays will cause burns. Now, so the clinical features, you see, earliest clinical feature is craniotabes, softening of the skull at suture lines. Then deformed skull. There will be a groove. There will be a groove between chest and abdomen. Now this groove is called Harrison sulcus. Now there will be multiple swellings at costochondral junction. They are called as rosary. Now, rosary is seen in two diseases, rickets and scurvy. The rosary of scurvy is painful. Rosary of rickets is painless. Rosary of ricket is round and smooth, whereas rosary of scurvy is pointed and angular. Pointed and angular. That is the difference between two kind of rosary. So both the rickets and scurvy, they have rosary, right? Your patient will have multiple deformities. Even wind sweep deformity your patient will have. So wind sweep deformity, varum in one limb and valgum in the other, right? Now, investigation. Serum calcium level are low or normal. In most of the patient, calcium level will be normal. Now, normalization is done by parathyroid hormone. So that is why parathyroid hormone levels would be high. Parathyroid hormone levels would be high. Same investigations are seen in osteomalacia, right? In osteoporosis, everything is normal. Calcium, phosphate, PTH, everything is normal. Now here, phosphate and vitamin D levels are low. Remember, our patient is a growing child. Bones are being formed. So, serum alkaline phosphatase levels are elevated, right? Now, X-ray will show three things: cupping, splaying and fraying. So, the first one is normal. Second image is showing you cupping. Third image is showing you splaying. Splaying means widening. Fourth image is showing you fraying. Fraying means rough edges. Right? Let's see this on X-ray. See, buddies. Here, cupping means deepening of metaphysis. Splaying means widening of metaphysis. Right? Here, you see. If you can see over here, first you see the rough edges. That is fraying. Then you see they are very, very wide. That is splaying. And then you see it is very, very deep also. That is cupping. Okay. Now treatment is you have to give your patient calcium plus vitamin D. Why? Because mother's milk is a very poor source. Mother milk is a very poor source of vitamin D. You know, the milk you buy from market has got too much vitamin D. Now, what are the normal blood levels of vitamin D? 20 to 40 nanogram minimum. This is the minimum one. Now, treatment is either you give your patient 6 lakh international unit intramuscular or 6 oral doses of 1 lakh international unit. Now, follow up, you can choose any drug, any units, 2 to 10,000 international units for 4 to 6 weeks. One liner question. If the treatment is satisfactory, phosphate levels will begin rising in 4 days. Radiological healing will occur in 6 to 7 weeks. What is radiological healing? You will get to see white line of Frankel, that is new calcification. Earliest it is seen around wrist joint. Okay. Now, NEET PG, they ask you 2 questions. First, when to do surgery? When the bones are skeletally mature. When to use braces for deformity correction? When alkaline phosphatase levels have returned to normal. Right? Okay. Whatever we could not cover, I'll share the PDF. Please do reach the PDF. Do read the PDF, and we will find a way. We'll find a way to be in touch. I'll find a way to answer your queries. Right? Aditya-ji, this complete video is enough, but buddy, see, we could not cover 2 important topics. Knee joint, only ACL injury is important, meniscus injury, sorry. And then second thing which we could not cover was tuberculosis. Okay. So I'll share the PDF. Please do read. Not very difficult they are. Okay. So as of now, please allow me to end the class. Right. We'll find a way to be in touch. Maybe by the Telegram group, or I don't know whether I'm allowed to share my YouTube channel over here or not, or maybe my Telegram group or not. But I'll have a word with sir, and then we will discuss how we can be in touch. Right? Thank you so much. You people have been like so sweet that you have been sitting here all along. Right? Thank you so much. Please allow me to end the class. Right? Hello? Okay. So what do I do? Stop streaming. Okay, right.